สวัสดีค่ะยินดีต้อนรับทุกท่านนะคะกลับเข้าสู่ IAEA Expert Mission นะคะครั้งนี้เนี่ยเป็นในหัวข้อของการที่เราจะพูดถึงในเรื่องของ strengthening optimization in radiological practice นะคะอาทิตย์นี้เป็นอาทิตย์ที่3แล้วนะคะซึ่งเราจะมาพูดถึงในเรื่องของ CT imaging quality metrics นะคะแล้วก็การเซตในเรื่องของ dose alert level ของในส่วนของการตรวจในของ neuro part นะคะ2 อาทิตย์ที่แล้วที่ผ่านมาเนี่ยอาทิตย์ที่แล้วเราหยุดแล้วก็2 อาทิตย์ก่อนหน้านั้นเนี่ยเราพูดถึงในเรื่องของ national DRL นะคะแล้วเราก็มีพูดถึงว่าการที่เรามี national DRL ออกมาแล้วเนี่ยเราจะเอาไปใช้อะไรยังไงซึ่งพอเราเข้าใจคอนเซ็ปต์ตรงนั้นปุ๊บเนี่ยเราจะเอามาอินทิเกรตใช้กับชีวิตประจำวันของเราว่าในการตรวจในเรื่องของ neuro part ที่เป็น CT head CT neck อย่างเงี้ยค่ะหรือว่า CT spine เนี่ยมันจะมีการดูในเรื่องของ quality metric ตัวไหนยังไงบ้างนะคะแล้วพอเราจะเอามาใช้แล้วเราจะมาอินทิเกรตในเรื่องของdose level เราต้องมีการปรับตัวไหนยังไงบ้างมีเทคนิคอะไรยังไงบ้างนะคะแล้วก็วันนี้เราก็ยังได้รับเกียรติเช่นเคยนะคะจาก expert ของเรานะคะดร. Sam Brady นะคะจาก Cincinnati Children's Hospital ค่ะที่จะมาพูดให้เราฟังนะคะ Good evening Sam hope you are doing well and welcome you to the this is week 3 for the expert mission that we are going to talk about CT dose CT imaging quality metrics and optimization and also setting up a CT dose alert level in neuro exam. So I give the stage to you. Welcome to, yes.
Thank you. Welcome, everyone. I'm grateful to be here again. Let me get my screen up. All right. We had a little break last week, but I'm glad to be able to come back. And so the first 2 weeks, we really spent the time setting up the discussion of diagnostic reference levels, optimization. We talked about various different aspects of what is image quality and how we can measure them. And then, of course, we talked about how we can measure and establish dose reference, not measure, excuse me, but collect and calculate and create dose reference, diagnostic reference levels. And we even reviewed all the data that you all have been acquiring and developing in Thailand, and we've reviewed some of that. So everything has been kind of very broad and general. And so now for this week on to the very end of these sessions, we're going to be focusing on very specific modalities and very specific aspects of each modality. So CT is such a large and complex modality. We will break this down over and discuss various aspects of it over the next 3 weeks. So today we're going to focus in kind of basically on the head, and we're going to focus on the image quality aspects of it, giving examples of how to set up and how to track image quality and optimize image quality for neuro CT. And then also, of course, talking about dose, setting up alert levels, and how we can use those to track and optimize the exposure to our patients. And then next week, we will focus on the body. And then the final week, and then the third week of CT, we'll be focusing on kind of more of the specialty, maybe cardiac and a few other aspects of CT. And so get this to move forward. There we go. The very first thing we need to really describe and have a conversation about is what is our optimization goal? And so there is a little flow chart right here, actually more of a web integration chart on the right-hand side. And it may seem very complex and actually very hard to read because when we talk about creating an image for interpretation by radiologists, these are actually all of the steps and aspects, the various different components and parameters that we need to get correct. And it's obvious that it's very complex. And so we need to kind of distill this down into a larger question. So what is it that we are trying to optimize? And if you see all the way on the right-hand side, you see this concept of utility. Where's my laser? Oh, I'll just use my arrow. All right, so the idea here is the use of CT as a tool, a diagnostic tool. And so if it is appropriately optimized, it will provide the right information to our radiologists so that they can diagnose the patient. So that is the ultimate goal of what we are trying to do when we go through the exercise of optimization. So correct image we need to get the correct quality, and so they can make the correct diagnosis. Now, there is a lot of interpretation as to, well, what is the correct quality and et cetera. And so let's kind of talk a little bit about this. So we're going to kind of break things down even a little bit more. So we're going to go from the high level utility, the discussion of how we use the image, and then we're going to break it down on how we can optimize it. Like, what can we do in each of our individual roles as radiologists, technologists, medical physicists, et cetera. You see here, I put a yellow box around actually the word image quality. And so you can see here the interconnections of what we will need to do to optimize image quality. So the first thing is, when you come over here, we can see image quality connects with the actual imaging task, the idea of disease characteristics. What is it that we are trying to image? And so there's always a reason that a CT is ordered. And so what is the answer, or hopefully the question that, what is the answer to the question that we can get, so we can pass that on to our physician colleagues. And then when you talk about the more quote unquote typical things we think about with image quality, image noise, image resolution, contrast, you can see here the overall, all of the various different features and parameters that we need to consider when we optimize the quote unquote image quality aspects that we are very familiar with. So to do this, it's just so much work for one person. And so we need to consider this as a team effort. And so here I simply put together just what I would consider the dream team, this idea of an optimization team. We need to have a radiologist, someone that has the insight on what they need to see. We need a technologist or technologists. They can give and provide insight on workflow and system operations. They, of course, are the ones using the machine. Medical physicists provide insight on fundamentals that will ultimately drive and affect the system performance. And then I actually add what is probably a slightly different from most people when they consider optimization team. We need someone that understands the computers, right? The people that run the PACS information technology. And so most hospitals will have a person or two that they are the ones that make sure all the computers are connected. When the CT scanner creates the image, they go up to PACS. PACS can create the hanging order and push it off to the proper reading room workstation. The images will appear as they need to in the right order, according to the series, etc. It's a very complex process. And so we actually need someone that can help us get the right information to the right location at the right time. So where can we start when it comes to protocol optimization? And so image quality is great at the image level, but when we take it up a couple of levels, we need to think of it more globally. We have a protocol. And so we have our ordering physician, someone, let's say a kid appears in the ER, they got in a car wreck, they hit their head, so there's potential for trauma. And so the doctors that need radiologist help, they're not thinking image quality, they're not thinking particularly, this CT scan. They're saying, I need someone to help me rule out traumatic brain injury. And so we can think of image quality kind of a little bit higher up. We can think of it as more of a protocol level optimization. And so here's just an example on the right-hand side of your screen of our protocols, or at least some of our protocols. You can see here, on the accordion side on this left part of the screen, I opened up, you can see we have under our CT neuro protocols, we actually have very high level, just a couple of different categories or subcategories, CT neuro. And then you can see just all of the various different protocols established here for a couple of our CT scanners. And so where do you start? Well, we have so many protocols for so many various different indications spread across a variety of different scanners. And all of the scanners may not be the exact same vendor, and so they'll operate slightly different. But the reality is a lot of these protocols are actually the same. And so a lot of them will have very similar technique factors, maybe the same KV, maybe the same pitch, etc. And a lot of them will have the same reconstruction parameters, such as the same slice thickness and recon kernels. And so what we really need to do is, it can be very overwhelming when you think about optimizing all of these protocols and for all of the CT scanners. But if we create a master spreadsheet that helps us group the similar protocols with the similar factors, we can actually then make a change to, let's say, image quality. Let's improve spatial resolution, improve the noise, whatever it is that we ultimately choose to change. And we can go back to our master spreadsheet and we realize that we need to make that change for these 4 protocols. And by doing that, we can actually make a larger change and larger impact to overall image quality across more protocols instead of looking at each one of them individually. And so we're looking at it as a parameter. If we want to improve spatial resolution, okay, that's fine. And these are the protocols that all use the same or similar parameters. So the same change for all of them will improve every one of them. And so what we want to do is we want to track these changes. We always need to summarize these changes. We need to make a running list of what we're doing. We need to indicate who makes these changes. And this is just mostly for historical purposes. When we make a change to a protocol, we need to make sure we understand when it happened, who did it, and why, so that if there ever needs a question, maybe ultimately it doesn't work out, we can go back and fix it. Or, after a couple of years, there may be just these questions of, why did we go this direction? And keeping a good history of all of the changes is actually very beneficial. It's probably just as important as going through and actually physically making adjustments to the image. I hope one of the things that you take away from this, when we're talking about image quality optimization, it's not as simple as just going in and changing, like reducing the noise in the image. Yes, that's one aspect of it. But really, when we're optimizing, we're looking at this holistically. We're looking at this really as a top-down. How can we make a change that will fundamentally help the entire process, from the protocols, maybe even the ordering side, from the ordering physician to the protocols, and how we list and store these protocols, and how we can keep them collected or collated. And so because this process is can be very difficult, or it's very intense because there's so many different parameters to adjust, one of the things that we really need to do is be as efficient with how we approach it. So let's start with, for example, the most common protocols, the one that's ordered the most frequently, or is the one that we tend to use the most. So in pediatrics, for example, we deal a lot with neuroimaging is actually one of the, at least for us in our hospital, is one of the most ordered CT scans. And so to make a positive impact for our patient population, to focus in on the very specific routine neuroimaging, it actually will help our patients in image quality and dose, and it'll help our radiologists. So find the most common protocols that's ordered, or you could even also look at the protocols that produce the highest dose. And we're going to talk about dose in the next talk, so I'm not really going to go too deep into that. Another way to look at this is, as you're going through and you're just on your day-to-day process, the radiologists are looking at a lot of different images, and every so often there's going to be an image that comes across that just doesn't look really good, and they're going to flag that. And when that gets noted, well, we collect that information. And what ends up happening is, if we have multiple radiologists over the course of days, weeks, and months making these comments, you may eventually see trends where certain protocols are not actually giving the proper image quality that the radiologists need for their diagnostic confidence. And so you can just look at the protocols actually that require the most review because of the comments or complaints that come back to the technologists and the physicists. So how do we do this? As I mentioned, you can sit down and you can simply just survey, and you can look at the radiologists. If you have radiologists that specialize in neuro, for example, and body, obviously we're talking neuro today. So you can go back and you can go look at maybe the chief of the neuroradiologist, and you can say, okay, hey, you've been looking at these images. Is there any one protocol that stands out to you or type of imaging series that just doesn't seem to meet your guys' needs as radiologists? But the thing you should consider is every radiologist is going to have their comment. Everyone's going to have their complaints. Some images may come across and the radiologist just may not feel like that was a really good or a properly acquired study. But one thing you should consider is, yes, that's one person's opinion. But when you look at the totality of it over days, weeks, and months of collecting this information, then you might see that trend as I referred to. And if you see that trend and it's a very specific, say it's the routine imaging for, I'm a pediatric physicist, so let's say it's for kids that are 2 years old to 5 years old. That one protocol, for whatever reason, just isn't, maybe the dose isn't set right. And so you look at it and you see that the majority of complaints are about that one protocol. Well, that's the one that we can focus on. Other ways we can approach this is you should consider from the technologist standpoint. There may be some protocols that when they bring it up on the CT scanner, that they are consistently struggling to acquire a good image. That something might be not correct. For example, the contrast timing that's been established for that protocol may not be actually proper. And so we're getting poor visualization of the vasculature. And so what are the protocols that the technologists are struggling with? And then, of course, and we're going to talk about this next, but you can look at the protocols, you could look at the dose distribution and compare that to the national diagnostic reference levels and see which ones maybe are a little bit too high. And the ones that tend to be high, well, we want to bring them down, obviously, to help keep risk low for our patients. But also the ones that are actually kind of high, we can bring down low, and we probably won't negatively affect image quality at all, just because the dose was probably set too high. And so that's actually a really easy protocol to fix. So we need to figure out a way to develop an intake process. There are different PAC systems that, I don't know exactly which of all the PAC systems that are in all of your hospitals, but I know that several PAC systems are providing a way for radiologists, so when they read through their study, they can flag not just an image, like a key image, but they can actually flag the whole series or one series or multiple series in that exam for that patient, and they can say that it was poor quality or subdiagnostic. They can make a comment, they can maybe do free text and say, this is why I don't like it. Too noisy, too grainy, too blurry. And so some PAC systems are allowing the radiologists to give feedback in real time. Other hospitals I know around, here in the US, they'll create their own little survey system where after they complete their review and they've finalized their report, another screen will pop up and say, was this study sufficient? Was the image quality of this study sufficient? They just simply have to click yes or no. And by creating a way to track this in real time, it gives you the optimization team the opportunity to figure out where the majority of the issues lie, instead of just simply asking radiologists or technologists. So if we can find a more blinded, probably a little bit more scientific way to track this, it's better. And that really just depends on the technology that you have available. But if you do have it, I highly encourage, reach out to your PACS IT team, find out if you have that feature available on your PAC system, because it really does make a big difference. And there are a lot of papers out there. You can actually just kind of Google this concept. I've read several papers in preparing for this talk. There are several groups out there that have been doing this for many, many years, and they have seen great success in making sure their image quality is consistent across all of their protocols. All right, and so obviously if you have this ability, you will be collecting data in the background, so you can have your PACS IT team run reports, and they can so that your optimization team can review where are the outliers, the protocols that are outliers. This is, excuse me, very much akin to reviewing rejected plain films. Just kind of how we used to do it in the old days. If a bad film was acquired as to overexposed or underexposed, you just throw it in the review pile, and then at the end of the month, you pull them up, put them on the light box, and then review them. This is old. We don't really do it as much nowadays, but the way that we used to do it, 20 years ago, that is still what we need to do. We just now are digital. We have to figure out a way to collect those quote unquote not good protocols that we put into our review pile, and so that we can then review them on a periodic basis. All right, so what we need to do is look for, so continuing this idea of optimizing the protocol itself, so we're still high level, we need to look at inconsistencies between similar protocols. So once again, I gave you an example as a pediatric site. We can't just have one protocol for a routine brain study. When you're imaging a neonate all the way up to, say, a 30-year-old or even a 16-year-old, there's so much growth and so much difference in the anatomy that we just can't use the exact same protocol. And so in our case, we have actually, I believe it's 5 protocols for the brain, and we partition it by age. And I'm going to really get into that in my next talk. But the concept here is the image quality should be consistent across all of those protocols. And so if there's any one of those 4 or 5 that just gives consistently bad image quality, well, that's the one that we need to focus on. All right, so we have the opportunity periodically to get new CT scanners. And I don't know how often your hospitals turn over new technology. Oftentimes, it's usually probably around 10 years. So let's say 10 years is about the right level. If you have the ability to constantly get new technology, well, that new technology comes with new tools, new abilities for you to have better image quality at lower doses, etc. And so every time that we get these new technologies, we need to be able to reassess our image quality. So that should be part of our optimization process of constantly looking at the new technology and seeing how we can leverage that to make better images. And I would say that it's not always just when you buy a new CT scanner, because the vendors of CT scanners are constantly building new reconstruction algorithms, new filters, new post-processing techniques, stuff that A, they may just give you because of your contract with them, or B, maybe something that you can purchase for a few $1,000s instead of buying $1 million CT scanner. And so you can have the ability to continue to upgrade your technology, even though you still have maybe a CT scanner that's 4, 5, 6, 7 years old. And so it's important for us to always constantly look at the new technology with every release, every update, and of course, every new scanner. We talked a little bit about this actually in the first week. One of the aspects of optimizing protocols, and is very important when we're establishing diagnostic reference level, is we need to make sure we're using the same language. When we call a routine brain at one hospital, it needs to be basically the same labeling structure at all the other hospitals. Obviously, this is important for diagnostic reference levels, as we've already discussed, but it's very important also when you have, let's say, 10 CT scanners or 5 CT scanners at your hospital, and you need to make sure your protocols are fairly consistent in the way you label them, so there's never confusion, there's never a doubt as to when a specific protocol is ordered, which scan technique that you're using. All right, so that was really just kind of high level. It was important to talk about the idea that when we discuss image quality optimization, we're not just going to talk about making better spatial resolution, less noise, and maybe enhance the image contrast. Those are steps that we're going to talk about today, but those, as you can see, are just a small little box. There are so many other aspects of image quality optimization that start at the protocol level and work our way down. So now let's get a little bit more granular. So we're going from top down, we're going to take another step down. when we talk about image quality optimization, there really are two different ways to look at this. There are technique factors that we can optimize that do affect patient radiation exposure. So I put this here in this red box. If you go over and you change tube current or MA or tube voltage kV, you are going to cause a change to the radiation output, be it good or bad, to the patient. And then there are other reconstruction technique factors that will not inherently change the amount of radiation that we use when we image our patients. So there are acquisition factors that we need to optimize, and reconstruction technique factors here shown in these two boxes. So let's talk a little bit about the technique factors that are based in reconstruction that do not necessarily directly affect the way we use radiation. Now, there's always, let me go back. There are a lot of, even though these image quality factors, they do connect to some dose levels, to some techniques. Let me say that again. Some aspects that are affected by radiation dose will impact image quality. But the ones down here that I highlighted in green, you can see the lines actually do not connect directly with the dose. So slice thickness is one example. Slice thickness on modern multi-slice CT is reconstructed after the scan is acquired. And so we do need to think about radiation dose when we talk about slice thickness, but changing the slice thickness from 0.5 to 5 or 3 millimeters to 5 millimeters in and of itself does not directly change the radiation dose that our patients get, because it's something that occurs after the image data has been acquired. We should, as a principle, always acquire every one of our scans using the thinnest sliced option available. So most scanners have their detectors. So if you're looking at it kind of craniocaudal, so you're talking the top of the body to the bottom, they have very small little elements that, when all added together, create the detector. And most of them are 0.5 millimeter in size. One vendor specifically uses one that is 0.625 millimeters, but for all intents and purposes, they're less than one. They're really small. And so we should always acquire every one of our images using this fundamental basic setting. Now, does that mean our radiologists are always looking at 0.5 millimeter images, slice thicknesses? And the answer is no, because in modern multi-slice CT scanner, we will use a total beam width. So we're going to acquire a certain slice over the body, or I guess in our case over the head, that, as in this example, is 20 millimeters. And because each of the detector elements is, for example, 0.5 millimeter, then what we can do is we can combine so many of them together to create one slice that is maybe, for example, 5 millimeters or 3 millimeters, etc. And so we can just add up all of those elements and create the slice thickness that we need. The reason, principally, that we want to create acquire all of our data using the thinnest data collection option available is because of our reformats. And when we acquire everything at 0.5 millimeter, we can slice and dice it however we want. We can make them axial, we can make them sagittal, we can make them coronal, we can do whatever we want, but because it's all acquired at 0.5 millimeters, the voxels are isotropic. And therefore, you get nice, clean, good-looking images in the, say, coronal or sagittal. If you acquire, and so this is an example of acquired at 0.5 millimeter, but reconstructed to be 2 millimeters thick. If you acquire the actual data using all of those detector elements that are 2 millimeters and then reconstruct them at 2 millimeters, you get obviously poor image quality. You get these what are called stair-step artifacts. Now, this imaging right here, these types of artifacts have largely gone away because of the way we use multi-slice. And this is not really a question. Almost all of your protocols, I'll bet you, are established at 0.5 millimeter, 0.625. And so you guys are always seeing this quality, this type of image quality. The only reason I bring this up is because more and more PACS systems are allowing the radiologists the ability to create their own reformats. They can establish simple, sagittal coronals, or maybe they can even create obliques. So unless you are sending the quote unquote raw data, the thin slice imaging to PACS, the radiologists are forced to create these reformat views using the thicker slice data, the 2 millimeters, 3 millimeters, 5 millimeters, whatever. And so when they create the reformats, the data looks very artifact laden. And so one way to look at improving image quality is getting all of the data, giving the radiologists actually access to all of the data, the thin slices, so that they can, on the fly, look at any angle they want if they need to. So that's just one way to optimize using slice thickness. So obviously, this is a kind of an educational aspect. So we just want to make sure we understand here. When we talk about multi-slice CT, we are talking about combining each of these individual 0.5 millimeter detector elements, and that will give us the overall and so forgive me, so each of those individual detector elements is going to have a certain thickness, and that's what we label T. And depending on how many of them we use to acquire the image, the number, or N, will give us what we call beam width. And so this is that 20 millimeters we used in that example, or 40 or 80, depending on your CT scanner's capability. So this is just an example of one I measured on one of ours. We have the Canon, we have several CT scanners from Canon, the old Toshiba Aquilion ones. So they're 16 centimeters or 160 millimeters wide, very large detector elements. And so we have 320 of these 0.5 millimeter elements. So what slice thickness should I use? Well, two things to consider. There's the first thing to consider, what I just described, is the total collimation, which is the beam width, the total number of detector elements that you're going to add up to use from your raw data. And then obviously the reconstructed slice thickness, which we've been talking about. So slice thickness is image task dependent. And we're going to go through a variety of different examples of why we would use reconstruct thin slices versus thick slices. So the first thing we need to do to consider optimizing is total collimation. There are 3 ways to image the head, or 3 ways to look you can think of imaging the head. We can use axial imaging, and that is where we use the widest detector coverage possible. As an example, if you have a Toshiba or the Canon scanners and the GE scanners, you have the ability to image out all the way up to 160 millimeters in one single rotation, axial rotation. Obviously, we can image using helical, and you can use a fixed MA and the largest collimation, which I'll describe in a minute, or you can use helical with tube current modulation. And in this case, you're not going to want to use the largest collimation, the largest beam width. So we'll talk about some examples of that. So the very first thing to consider, so this is just some data that I measured. I think it was a couple hundred patients where I basically went through and I measured just the overall length, cranial to caudal, of the cerebrum. So how could we cover all of the brain in one single rotation? And so you can see the size, cranial to caudal, the length of the head, from the littlest of kids all the way up. And obviously we're pediatric sites, so I don't have a lot of patients over 30. But you can see the data follows in this nice logarithmic trend. And almost all of the patients that I measured had head lengths or brain lengths that were less than 160 millimeters. In other words, if you have the wide cone beam CT scanners, such as Canon or GE, in theory, you should be able to set up your field of view so you can do a single rotation and get your entire brain in one caption. And this is great because this is, bar none, the fastest way to acquire an image. Because most of these two scanners, they both scan currently at 0.275 seconds in one full rotation. So if you're using either one of these wide angle, large coverage scanners, you can acquire the image of the brain in less than a half a second, in less than 0.3 seconds, really. The newest GE system has been making this claim now for about 5 years, 6 years. Well, yeah, it's probably been about 5 years, 6 years now. They haven't quite got there, but they keep saying one day they're going to get their rotation time down to 0.2 seconds. They're getting close, but it's mind-boggling to think that we could acquire the entire brain acquisition, the brain scan, in 0.2 seconds and be done. That's mind-numbingly fast. One caveat to this, I know Canon we have Canon scanners, for example, those Toshibas, and they've known this artifact has been around. They know about this, and this artifact's been around for a while. But when you acquire the scan using 16 centimeter single rotation, there is this banding artifact that has been present. And so for us personally, we actually do not do this anymore. We do not use wide angle 16 centimeter coverage. That said, we also have a GE Revolution, and I've never seen that banding artifact. So hopefully you guys don't have that artifact, because I'm actually a very strong supporter of the idea, if you have wide coverage, use it for the brain, because it is quick. It is as fast as can be, especially when you're imaging kids or maybe older adults that can't lie still for a very long time. And so you can get them in, get them positioned, and you're done. The scan is done in less than 0.3 seconds. Now, when we talk about axial imaging, historically, we used to do what's called step and shoot. And what that basically means is we would acquire one axial image, maybe 20 millimeters, maybe 40 millimeters if you have the ability to. You acquire this, and then the patient would translate. The patient would go in a step, and then would acquire again, and then the patient would step through again. And so basically you were just imaging kind of like a loaf of bread. You're just slowly acquiring each slice through the brain. That is the slowest way to image. And with modern technology, this is probably not the best way. It's typically the highest dose and the slowest way to acquire. So it's more prone to artifacts, to misregistration, etc. I highly do not recommend this if you have the technology to do either wide angle, like I said, or any of the next two options, which is using helical. All right, so the next option is helical using a fixed MA, and we're going to use the largest coverage possible with a helical acquisition. And to make it as fast as we can, we're going to use a high pitch technique. So most scanners are going to be limited to a roughly somewhere between 40 to 80 millimeters total beam width when you're using helical. So if we set it up, if we set it up and we acquire, the planing radiograph, or the quote unquote scout image, but if the patient then moves or is somewhat misregistered from the original scout, the problem is, if you're using tube current modulation, the system is going to be confused, and it's actually going to calculate the wrong MA for the certain positions in the body. So that's kind of why using a fixed MA is actually a good thing. We use it for our kids, for pediatrics. I know other pediatric centers use tube current modulation, so it's really just a choice. But fixed MA is a little bit more lenient. And so if the patient lying in this on the scanning table, his head is not exactly lined straight. Well, if it's off on an angle, the scout image is going to show that it's thicker through certain projections. And therefore, when you do tube current modulation, it's actually going to at times calculate for higher MA, and instead of a nice, properly centered and aligned head. When it comes to CT scanner, especially in the body, and we'll talk about this next week, but you really got to get the body in there, centered, and aligned properly, or when you use tube current modulation, the system will actually go to extremes to give you too much or maybe even too little MA. So anyway, using fixed MA removes that option or removes that problem. So if you use high pitch and plus the largest largest beam width available to helical imaging, that equals the fastest acquisition. Well, I should say the second fastest acquisition. Obviously, the fastest is a single spin at 0.275 seconds. Nothing faster. All right, then there's the third option, which is using helical imaging with tube current modulation. Now, when you do this, I highly recommend you use a pitch of less than 1 and a beam coverage somewhere around 20 millimeters. Now, why is that? If we look at this, obviously this planar radiograph, the planning radiograph or the scout image of this kid, what you see, of course, is you're going to see a constant changing angle of the skull, of the calvarium. And so therefore, when the system is going through and measuring the thickness here and the thickness here and the thickness here, and of course this is being the thickest right here, it's going to be calculating the MA needed to penetrate to give you the right image quality. And so it's going to need the most MA through the thickest portions and the least MA through the thinnest portions. If you are using a wide beam, let's say a larger area coverage, and a fast pitch, the system cannot change the MA going from low MA to high MA fast enough. And so what the system will do is it'll default to the highest MA, even in the areas that don't require high MA, in these small, thin areas. And so using a lower pitch, a pitch less than 1, and a smaller beam coverage allows the system to modulate more appropriately and actually allow the system to use lower radiation in the thinner aspects of the body, or in this case the head, and the thicker aspects over here. The caveat to that is you need to make sure you set the appropriate MA limits. And so if the system is calculating which MA it needs through this area of the brain versus this area, well, you need to make sure that it sets the proper range, that there's an appropriately low MA and an appropriately high MA. The system will pick an MA between. If you don't set those right, say it's too close together, the system can't modulate. And if they're set so far apart, well, the system might actually pick a too low MA or at times a too high MA, and it's just not appropriate. And so knowing what noise index, if you're GE or SD value, if you're Canon, or the quality effective MA for GE and basically Philips, because they basically have this, excuse me, not GE, Siemens and Philips, they basically have the same idea. Knowing which parameters you set will help the tube current modulation properly modulate. All right, so moving on from, that was beam width. We set the overall beam total collimation. Now that we've acquired the image, however we've acquired it using one of those three options, now we're going to pick which slice thickness we're going to present to the radiologist. And as I mentioned, this is image task dependent. So I took all of the, most of my slides I took just from random place I found on the internet to present my idea. But the concept that I talk about, image task dependence and slice thickness, came from this publication right here. So if you want to get more information, I recommend it. It's a good read, and it's relatively new, well, relatively recent, 2016. So there are times where we will want thinner slices. So we're talking slice thicknesses less than 3 millimeters. These are ideal for detecting linear skull fractures. And so if you have too thick of if it's greater than 3, maybe 5, 8, 10 millimeters, then this will be you're familiar with the term partial volume art, where if you're thinking in the z-axis, if you're thinking of a voxel, the more anatomy you add into it as an average will cause small little linear fractions to just disappear. So the time where you want to use thin slices in the brain is usually when you're looking for these fractures. So the next level up would be somewhere between 3 to 5 millimeter slice thickness. Down in the posterior fossa, kind of down to the skull base, we are prone to a lot of artifacts. And that's just because there's a lot of bone. This bone causes a lot of these beam hardening issues. And so if you're using a thicker slice, you're going to see a lot more of these artifacts. A thinner slice, however, wherever you want to say, I know I said 3, maybe you could say 2.5, whatever it is, you can see how these artifacts really go away. All right, the next level, somewhere around 5 to 8. Now, these are all just general numbers. I'm not saying you absolutely go tomorrow and turn all your, or today and turn all your slices to 5 or 8 for these particular indications. This is just something, it gets you in the ballpark where you then have a good conversation with your optimization team as to what you need. So generally speaking, somewhere in the 5 to 8, now what we're trying to do is we're looking at the brain, we're trying to visualize the brain parenchyma, we're really trying to differentiate the gray-white matter. And in this case, having a little bit thicker image uses that partial voluming to our benefit. And so if we combine a little bit of the, if we are able to look at kind of the effect of the overall thickness of the gray-white matter as we're going along the z-axis or the craniocaudal axis, then it can kind of make the gray and white matter stand out a little bit. The gray matter and the white matter differentiator stand out a little bit more. So too thin of a slice, and you really lose a lot of that information. Unfortunately, gray and white matter really have nearly the same Hounsfield unit. I mean, they're just that compared to obviously CSF fluid, bone, air. I mean, gray and white matter are, for all intents and purposes, almost the same electron density. And so that's why they're really hard to see. So making them a little thicker gives us that ability to kind of just average more tissue together to get a better differentiation. Somewhere between 8 to 10 millimeter slice thickness is great. You know, when we're looking at the cerebrum and, you know, supratentorial compartment, when you have a lesion or, a bleed or something that just has the potential to look that a little bit different in electron density or Hounsfield units than their surrounding material, well, the thicker the slice, the more it's going to stand out or more it's going to differentiate from its surrounding. And so in this case, being able to look at maybe lesions, tumors or whatnot, a thicker slice is actually a good thing. Also for, like I mentioned, for bleeds, for strokes, other issues in that effect. So it's good if we can set these slice thicknesses up a priori. In other words, the patient comes in, they're on the table. We're going to either acquire a single axial spin, or we're going to pick one of the two helical scans, being it with fixed tube current or tube current modulation, either one. And then we have the thin data that we will then we'll add together at various different slice thicknesses. Being able to give the right image for the right clinical indication is very important. So does that mean we have multiple protocols? That is one approach, where you could have a protocol where you're looking for skull fractures. Another protocol that would be looking for lesion detection or stroke definition, gray or just general gray-white matter differentiation. But now we're talking 4 or 5 different protocols because they're all different clinical indications. Now, the acquisition itself, the MA, the KV, the dose to the patient, that all is the same. It's just different indications. And so there's what you can create different protocols for different indications, or you can create more of a universal protocol that is then just one protocol you have to optimize. And the images will then either be post-processed afterwards. The technologist sets it up, will run a script that will set the right slice thicknesses, send them to PACS, or you send the raw data to PACS, and the radiologist can then actually process them as thick as they want using the new, if they have that feature on PACS, giving them the ability to look at whatever slice thickness they want on the fly. All right, moving on. Going down that list that I had. So slice thickness was one, field of view, setting up a field of view is another approach to that you can, a parameter you can change that does not affect patient dose. So this is where almost all modern CT scanners acquire their data in a 512 by 512 matrix. There is one vendor that I can think of off the top of my head that allows the user to actually change that. But for the most part, they're all 512 by 512. That's why in the denominator, no matter what display field of view, when you set the scan coverage, you also set the display field of view. The technologists obviously know what I'm talking about. And so whatever that value is, it's always divided by 512. The small display field of views will always have the smallest pixel sizes. Therefore, the smaller the field of view, the better, finer resolution you can view. And so this is actually one of those important things that a good way to optimize and get good image quality is have good technologist technique. You don't want just large fields of views. Obviously, you don't want to clip the data or the patient anatomy, but if your technologists are always setting their field of views to the appropriate size of the anatomy, they're going to maximize the resolution of the image. And so spatial resolution in this case is optimized. So here are two acquisitions. It's one acquisition, excuse me, but it's processed with two different field of views. So obviously, if you're just looking at the whole head in this axial view, if you've set your display field of view of 500, your pixel value is basically 1 millimeter. So each one of the pixels in this is 1 millimeter. Now, if you do the same, but you set the display field of view at 250, now your pixel value is now 0.5 millimeter. So it's obviously zoomed up, but not only is it zoomed up, the structure is going to be a little bit finer. You're going to be able to see this. You're going to see the finer structure better. So if you took this image right here, and if we zoomed it up, the anatomy, the bone structure here would actually look a little blurrier, and you wouldn't see as great detail in the bone as you would in this. So setting the field of view to the right size of the anatomy so the radiologist can see it is the best thing. If you acquire just a large field of view for every patient, the spatial resolution will not be properly optimized. Okay, image reconstruction kernels is another one to look at. The reconstruction kernel fundamentally changes how we see the image data. The thing that we're very familiar with, oftentimes the radiologist uses this as a tool, is the windowing and leveling. And that's this idea that in CT imaging, we have electron density. And so bones are very dense. They have a lot of electrons. And so they absorb the photons much easier. Therefore, they always appear on the white side of the scale. And air, of course, it isn't very dense. Therefore, there's very few electrons in it. So they do not absorb hardly any photons as they pass through the patient. And so they appear black. And so at any given time, the radiologist cannot see, their eyes cannot properly differentiate this range of, say, 1,000 to -1,000, or even 3,000 on the bone side to -1,000. That's just too many grayscales. The image would look washed out. So we do what we've been doing this for years now. Is what we do is we set the level, kind of the center area, the type of tissue we want to really focus on. Soft tissues be somewhere close to the 0 by water. If we set the window level over here towards a negative value, we're going to be focusing on less dense electrons, tissues such as air-filled cavities like lungs or fat. They appear darker. And obviously, if you shift it on the other side, you're focusing in on the bones or the contrast-enhanced tissues. And then we set the window width just to give us the overall range of the grayscale images we want to look at. So if you take the image, this brain's, and we reconstructed all the data using a quote unquote soft tissue kernel. Now, if we change the windowing and leveling, we can obviously focus as we shift along that horizontally along that scale, we're focused here on kind of in the center. The level is about 40 and the width is 150. So it's more looking at soft tissue. And that's why the bone is just white as can be. And the air is black as can be, and whatever fat there is in there is also dark. But the soft tissue itself is generally just gray. But when you slide that over to the bone, because we used a soft tissue kernel, we didn't actually accentuate any of the resolution or any of the features of the bone, and so it just looks all washed out. We can see the bone better, but we actually cannot make any diagnostic. We can't answer the diagnostic question of is there any issues with the bony anatomy, just because we haven't properly reconstructed the bone itself. And so you see here on the right hand side, now I've used a bone reconstruction window, a bone reconstruction kernel. And so when we look at the windowing width and windowing level for a quote unquote bone window, you can see now all the structure of the bone, high resolution, good definition. And if we then compare that to the soft tissue kernel, you can see that we are fundamentally looking at the anatomy differently depending on the kernel. And so one of our image quality optimization is to make sure we're using the right reconstruction kernel for the right task. Now, every vendor out there has just a slew of reconstruction kernels. And you have to, as an optimization team, decide which one is the most appropriate for the radiologist. So these are just examples here. I put actually in real small fine print down here. These come from a GE Revolution. You can have the exact same effect from a Canon or a Siemens, etc. They all have this idea of a differentiation of different reconstruction kernels. And you can see how on this scale of looking at bone, you can see on the left-hand side, they have the quote-unquote bone reconstruction kernel, which is actually probably the least sharp kernel. It's the least sharp of the sharp kernels. Whereas if you go all the way to the edge HD, the structure is just as fine. You can see just really subtle details in the bone. Obviously, the noise itself is also accentuated because it's taking every teeny little edge in the image and it's accentuating that edge. So be it noise or be it bony anatomy, it's accentuating that. And so how is this? Now, remember, day one, we talked about the various different image quality metrics that we can use to identify how to properly optimize the image. And one of those wonderful tools was the noise power spectrum, as shown here on the y-axis, or the NPS. The NPS allows us to look at the total amount of noise in the image, which is the amplitude, the number along the y-axis, and the texture of the noise that is presented to us, i.e. the frequency. And so a low frequency set of data, a curve that is centered on the low frequency side of the spectrum, will have softer noise and softer edges, and it will have less, the noise itself will not appear as intense to the eye. Now, if you have a filter or a reconstruction kernel that accentuates, you see how it's accentuating this side of the scale, the high frequencies, the noise looks very sandy. It's very fine structure. So setting the right kernel gives you a difference of texture, of an appearance of how the image looks. And so the noise power spectrum, when you calculate that, it tells you what you're going to see in the image after you reconstruct it. So looking at this, this is once again, just, you don't really necessarily need to understand all of the details of this, but when you look at the different reconstruction kernel options, obviously you can go in like I did a couple of slides ago, and you can just line up 5, 6, 7, 8, 10 images across and just have the radiologists on your optimization team look at it and say, I like this, don't like this one, like this one. That's one way to approach it. Another way to approach it is to calculate the noise power spectrum of each of those. And you can see from the spectrum what you will actually see in the image. And so interestingly enough, you can see here, this HD edge right here, it has a bimodal filter. So accentuates the lower frequencies and the higher frequencies, and the higher frequencies are actually in amplitude a little lower. The idea here is it's trying to not have as strong a sandy texture overlaying the image, but yet maintain the same structure in the bone. And I hope you can appreciate that the structures in the bone, that the fine detail that you see here is actually the same as this one, maybe even just a hair better, but the noise texture itself is not as coarse, as sandy and fine as you see here in this Ultra HD, which is the yellow curve, which you can see it tamps down, it tries to delete and remove all that low frequency stuff and really accentuate that high edge. So every edge in that image is really strong. All right, so the other thing so those are the reconstruction kernels. So once we acquire the data, we apply the kernel creates the image. Now, we can also now post-process the image after the fact, after it's been reconstructed. There are various different filters that we can apply. These are filters that can be applied at the CT scanner itself. They can be if you have a image processing lab where all the images are sent to a group and that group then does all these fancy things. Or, like I said, a lot of these newer PAC systems allow the user, the radiologist, to apply these filters. So, looking at, this is just one example. You can see here, we can optimize the appearance of gray-white scale. And here I acquired this image and I set it with no enhancement level 1, 2, and 3. And at every level, what we're trying to do with this filter is we're trying to really differentiate the gray and white matter. And that's all it's doing. It's not a differentiation of the kernel. We're not changing the dose output. So there's really no penalty to this. It's just trying to make it so the gray and white matter stand out subtly a little bit more. And I would like to believe, if you look at this image, it is subtly that much more, evident than this one right here. All right, so the other aspect we should consider is the type of algorithm we use. So most modern day reconstruction algorithms are always trying to do one of two things. Mostly remove image noise. And then the other one it's trying to do is some of them will try to sharpen the spatial resolution or sharpen the edges. And so the two most common one, the most common one is, and I forgot to list it was filter back projection when we're talking about the head. The other one is iterative reconstruction. And the newest one is the deep learning one. I talked a little bit about this the first week, and next week we're going to talk about it much more because deep learning is actually a lot more used, is being used more in the body. So as I mentioned, the most common one is filter back projection. We've been using this for years and years and years and years, multiple decades. It's the most common one. It's the one that we used almost from the very beginning. But then in 2009, we started using iterative reconstruction. There are various different flavors or different ways to use iterative reconstruction, depending on the type of scanner. And I'm not going to go into all the detail. That's a talk all in and of its own. But now, fast forward to 2019, 2020, there was a rollout of these new deep learning scan technologies. So far with Canon and GE, I'm sure Siemens at some point and Philips will also have their version. So here is an example of filter back projection and the new deep learning reconstruction level 1, 2, and 3. And these I processed on our GE scanner, but like I said, Canon and GE have these similar deep learning reconstruction algorithms. I hope you can see, like I said, the two principal things it's doing is removing noise. So this image all the way on this side of the spectrum is a lot less noisy than the original filter back projected image. And they're trying to sharpen the edges, but I would argue that the edges aren't as sharp as these. And that is because when we do deep learning or iterative reconstruction, the way those algorithms work, there's always just a little bit of the edge that is blurred, no matter what they do. They're getting a lot better. The deep learning ones are way better than the original iterative reconstruction ones. But here you can see this little blood vessel here, filter back projected, nice, conspicuous, good, strong edges. And this one, and this has come from our Canon scanner that uses AIDR 3D, which is an iterative reconstruction algorithm. No matter what, no matter which flavor, mild, standard, strong, or enhanced, no matter which flavor of AIDR 3D, they are all going to have just a subtle blurring of that edge. So when it comes down to it, most head scans are still using filter back projection. As much as we've been for the last decade using iterative reconstruction and now moving towards deep learning, the reason most people still stay with filter back projection, is because of this. It still preserves, it is the reconstruction algorithm that provides the strongest edge preservation. The problem is it's also the noisiest one. And so that's why our head doses tend to be a little bit higher than our body doses. That, and we have a big thick skull. It's hard to penetrate that. All right, so just kind of wrapping up here. One thing to consider here is the fact that we've been talking about various different image quality optimization metrics. And as a physicist, we speak a very specific language. When we're talking image quality, I'm thinking noise, I'm thinking resolution, I'm thinking, noise power spectrum, I'm thinking drawing ROIs and calculating contrast to noise ratio. I'm trying to do any one of these things. The problem is, on the flip side of that, the radiologist that looks at these images and reviews them so that they can make a diagnosis, they are not thinking noise power spectrum. They're not thinking MTF. They're not thinking CNR. They're thinking detection accuracy, sensitivity, specificity, etc. And so we need to, as a team, kind of draw connections to these, because I can go in and make these calculations, noise power spectrum, and I know that they will directly affect the detection accuracy of our radiologists. And so that's one of the main reasons why obviously we work as a team. So, but the point here is all the NPSs I can calculate, all the MTFs, all the CNRs that I can calculate, we still need to make an assessment of the accuracy or the sensitivity, specificity, the diagnostic confidence. We need to make an assessment of the diagnostic confidence of the radiologist. This is a slide I presented to you on week 1. If you have the ability, after you've gone through and you've made some image quality assessments and you've made a protocol or technique change, now you want to just make sure that A, it's better, or B, at the least, it's not worse. And so if you have the ability, you acquire maybe a week, 2-3 weeks worth of data, and then you do one of these calculations where you can go and look at the positive predictive value, the accuracy, etc. Now, not everyone has the expertise to do this, B, the time to do this. So I presented this option to you that first week. And that is where you use those physics metrics that we can calculate using phantoms, using water phantoms or plastic phantoms. And we can calculate the MTF, the noise power spectrum, all of those things. And these calculations will predict how a radiologist will perform. And they're very good at predicting that. So if you don't have time to put a million images in front, or that's an exaggeration, a couple hundred images in front of radiologists, and you get 3 or 4 of them to make assessments, that's a hard thing to ask of them. You can do it mathematically. But the minimum you should do is you need to have when you go in and you've determined that we're going to make an assessment of, say, the brain imaging, of routine neuroimaging, you need to have a champion, someone that can help so this is a radiologist, someone that can help the physicist and the technologist determine what changes need to happen to the protocol. And then once those protocols have been implemented, the changes have been implemented on these protocols, that radiologist, that quote unquote champion, the person that is in charge of it, will be there either at the CT scanner or at least in the reading room and they're watching as these new images come across. And so that day one, when you go live with the new changes, they're there to at least make sure nothing goes wrong. So this is the kind of the minimum that should happen. Obviously, the best is if you can do these big fancy statistical tests, but at the minimum, when you make those optimization changes, have someone there to make sure when you made the changes and you changed a different reconstruction kernel or you changed the slice thickness, you changed something, that you didn't do it and caused a negative effect. All right, so we've talked about the team optimization effort. We have talked about image quality and how it can be modified actually without affecting any patient dose. All of the many things we've talked about were just steps and examples on how we can make positive changes to image quality without changing patient dose. Next talk, we'll talk in a few minutes, we'll talk about how we can make changes for image quality and dose. So where did we start? We can begin with getting either feedback from radiologists, technologists to identify which protocols need the fix, need to be looked at. Obviously, we can look at protocols that use the highest amounts of level of radiation because they're the ones that we can actually lower easiest, radiation dose lower, and still not affect image quality. And then we always want to, as I just said, we need to have a way to review the changes to the image quality after we've made those changes, either using a reader observer study, either a mathematical reader observer, or at a minimum, that quote unquote radiologist champion that will kind of look over the shoulder of the technologists and make sure those images as they come across look good. All right, that's all I have for you. So for this talk, at least. I don't know if you want to do question and answer now or wait till the end, but I'll turn the time back to you, Tanya.
Thank you so much, Sam, for cover this topic. And one key images that key message that I get from you is we are teamwork. Not only radiologists or technologists or medical physicists, we need to work together to help with to improve image quality and get the optimization to the patient. So if there is any questions from the audience on Zoom or Facebook, please feel free to raise up your hands. We can unmute you to chat with our expert. So one thing, Sam, today we have the audience from Bhutan and also from Vietnam attend your lectures. So this is
Wonderful.
A good thing that we move forward in this region. So you talk about the technique like a wide angle and helical fixed MA and also helical tube current modulations, right? And you talk about like the fastest one is an axial wide angle axial image that is like a 0.2 second. And how about other technique is like a 0.3 second something?
So yeah, so obviously the fastest you go is if you do a wide beam width, so 16 centimeters, 160 millimeters. That will for all kids and most adults will cover the cranium, and you can't go faster than that. But if you do a helical, where now you're going to transition down through that same anatomy, you have to deal with the pitch. So if you're going at a high pitch at a fixed tube current, and you're using hopefully the largest beam width possible, either 40 or maybe 80 millimeters, now you're talking less than a second. So it's not a 0.275 seconds, but it's still pretty darn fast. Yeah. And if we're talking now where we're using a pitch less than 1, and we're doing, say, about 20 millimeters, so it's not as quite as large a beam width, but it gives you the best modulation, the best opportunity to tailor the dose from the thinnest part of the head to the thickest part of the head. Well, thinking of it this way, then yes, we're getting really good dose modulation, but now we're talking about a scan that'll take more than a second, maybe 2 seconds, because it's going to go really slow as it's trying to optimize or modulate the dose all the way down through the head.
Very less than second and maybe 2 seconds. I don't think it cause many issue for me as a radiologist, but I'm not sure in terms of like an image quality, it's probably not that much difference.
In
my
all
opinion.
three of those options, image quality should basically be the same. As we kind of talked about it, the best, obviously it's the reconstruction kernel, it's the different filters we use, it's those things that will change the way the image looks. You know, for us in pediatrics, and I know you look at pediatric images all the time too, Tanya, is the name of the game is we want to go as fast as we can because kids don't always cooperate. And some adults don't either. Let's be honest here. Some adults, they get claustrophobic. They don't like having their heads inside the CT scanner, or they get older and maybe they have, you know, they can't hold still. They have the shakes, or maybe they have dementia, so they don't pay attention as well. And so if we can go real fast, then we can hopefully capture that. And so they may not be perfectly cooperative, but we can still get them on the scanner, get them comfortable as much as possible, and then boom, we're done. And that's the most perfect world. And so for kids, that's great because we can reduce the amount of sedation and or anesthesia. And there are risks associated with sedation and anesthesia. And so if we can remove that, then we may not have changed radiation dose, but we have lowered a different type of risk.
Great. Yeah. So, but which means like that three image acquired that are like only like maybe 1 or 2 seconds, the maximum to get images. So, which means like not much difference in terms of like a time of the scan. And then, right.
I was going to say, it'll make a big difference next week when we talk about the body.
Yes, but for the brain, probably not. And for the brain itself, compared with the fixed MA and dose moderated, I don't think it's much difference in terms of dose because this is like a very thick part and you have like a skull. So that's why like age has the major effect because the young kids have very thin skull, but when you get older, you have like a thicker skull, which means we need more dose, right?
Yep. And we're definitely going to talk about that in our next talk.
Yes. Okay. And another questions from the audience in the chat box. So if we reduce the scan FOV, how the patient's radiation dose in case we use the auto MA?
Yeah, that's a great question. So when I talk about the scan field of view, when you think of it in the sense of setting it so you can optimize the pixel depth or the pixel width. So you're setting, you've done the scout. So you've set where you want to do the beam width. And if the scan field of view itself, so I guess I should be very clear. There's 2 ways to think of it. There's the scan field of view, which is the overall anatomy that we're going to image. Obviously, that will affect dose. If you have auto MA, and so kind of looking sideways here, you know, I'm thinner here than I am here, it's going to use less dose here than here. And so depending on how thick my scan field of view is, will depend on ultimately, you know, how much radiation is going to use. So if I'm using a large scan field of view that's going from the top of the upper apex of my cranium down through my eyes, past my orbits, then here you're going to obviously change the auto MA is going to change quite a bit from the top down to the bottom here. Yes. But the other thing that I talked about was the display field of view, which is the overall aspect of how much area that you're imaging. So if you have a large display field of view, so there's going to be a lot of air in the image, it's going to make all of the anatomy actually look smaller because the pixels are different sized. Now that, if I put my display field of view here versus here, will not change dose. So we don't have to worry about that. Now, if you change and you set it so your scan field of view is like this, but you put a lot of air, so you set it up here, it can have a small change because the system is going to go air here. And so it's going to have a really, really low MA. That auto MA is going to be really low here. And the minute it gets to the top of your cranium, it's going to need to ramp up. And it's hard for a CT scanner to go from low number to high number really fast. And so there will always be a kind of a gradual ramping effect. And so if you put a lot of air above the head, well, the problem is the system is going to not actually get the right dose at the top of the head. It's going to take a little bit before the scanner gets in before it ramps up. And so setting a good scan field of view here and a good display field of view here is the best optimization technique for patient dose and image quality.
So you mean, so let me like rephrase on that things. So which mean like the radiation dose depend on the coverage that you do. Yep. But when you acquire the image, it's like the whole things in your body that you need the coverage. So let's say you want to get a CT of the thoracic spine. When you like when you acquire the images, it's going to be like you're going to include chest and thoracic spine when you acquire the images, but you need to make the images for the radiologist. That's why you need to have a display field of view smaller to map up or zoom up the image of the thoracic spine and put the filter and those things, right? But which mean if they order CT, chest and thoracic spine, you scan patient one time and you have the display image for the chest and also display image for the thoracic spine. Is that correct?
That's correct. So yes. And so in that case, you can scan once, but you reconstruct normal. So you get the chest, and then you do a much more collimated reconstruction of just the vertebrae. Yes. And so the vertebrae, in that sense, you'll see a lot more of the fine structure. If you're lucky, you might even see some of the nerves, but mostly you're just looking at the bony anatomy. So you'll see maybe a fracture or whatever it is that you're looking for. And so in the question that they're asking is, will dose change between say 200 and 250 or 250 versus 500 millimeters? And the answer is no. There is that small, like I said, if there's a little bit of air right here, it can affect it, but it's not going to make a huge difference. If there's air right here versus here, no dose effect, but the image quality will be poor or poorer.
So let's put on a different scenario. Let's say if the doctors order just CT thoracic spine, and afterward they said, yeah, can I look for, do you have any chest images that we can look for the thoracic spine? So which means, can we go back to the scanner and ask technologists to change the display field of view and mark it up so we can see the lung findings or chest finding?
So it depends on how it was acquired. So the CT scanner, obviously of the chest, it's going to image all of this anatomy because it's in the scanner. If they acquired it where you set your display field of view, you can go in and you can change that display field of view. And so obviously if they set it so that they only reconstructed initially just the vertebrae, so the thoracic spine, now the doctors want to see everything. Well, they just call it the technology and say, okay, open up my display field of view. I want to see the full chest. And so that is always an option. You don't necessarily have to go back and rescan. It's different than MR. In MRI, you image your field of view. And if you want a different field of view, you have to re-image the body again. But that's MR. So luckily for CT, we get all of this data always. And so it just depends on how we display it. And so if the radiologist says, hey, I want to see something a little different, I want to see more bony anatomy, the technology can go back and reconstruct using a bone kernel instead of a soft tissue kernel. And okay, if it's in the chest, you get the bone kernel and maybe lung kernel and maybe soft tissue kernel. All the same dose, no difference, but different views or different looks of the anatomy.
I see. And can you reiterate again on the radiation dose when we acquire the images as for like the thinnest slice, maybe 0.5 millimeter compared to 5 millimeter? When we acquire the images, it's like the same radiation dose.
So yeah, and we're going to talk a little bit about that in the next talk. So we always set it up. So for example, if I'm doing a 160 millimeter slice here, I'm going to acquire the data at 320 detector elements, each at 0.5 millimeters. And when I reconstruct that 0.5 millimeter data and you as a radiologist look at it, it's going to look horrible. It's going to look really noisy because we set the dose. We know that eventually we're going to take those 0.5 millimeters and we're going to create 5 millimeters or 8 millimeters or however thick. We're going to create thicker sliced images. And when you create thicker images, you're averaging more data, and more data averaged together reduces the amount of noise in the image. It's just it's signal to noise ratio. You get more signal, so that little bit of noise, it just kind of disappears in the image. And so when we build the protocol, we are going to acquire everything at half that 0.5 millimeters, but the dose level, the MA, is set so that we will eventually reconstruct it at 5, as an example, 5 millimeters. And that's what the optimization team has to decide. We look at it and say, okay, for this clinical indication, we are going to provide the radiologist 3 millimeters, or let's say 2.5 millimeters and 5 millimeters. But we're going to optimize the dose for 5 millimeters. So the radiologists will see a thick image that'll look nice. It won't have a lot of noise. And then they'll also look at a 2.5 millimeter thick image that's going to look noisier, but maybe because it's thinner, they're looking for fractures. And even if the image is noisy, you can still see a fracture. But the thicker image would be if you're looking at the parenchyma, and now you're trying to differentiate gray-white matter, you're looking for mass effect where it's shifted, or you're looking for subtle infection or tumor, then you want to make that image the best looking. So you pick the slice thickness that you ultimately want to look the nicest, and you set the dose for that, even though you're still acquiring everything at 0.5 millimeter.
Yes. Okay, that makes sense to me. Yeah. So I think we don't have any questions right now, so you can go to your next talk, and maybe we have more questions come up later.
Yeah, that's great. All right. All right, you should now see my slides. And all right, so we are going to move on. We've already started talking about dose. Thank you for those questions, Tanya, and for the others that have asked the question. So now we're going to kind of shift and talk a little bit about how dose affects the image quality, the other side of the equation. So when we talk about radiation dose, obviously remember, this is the big picture here. We're talking about diagnostic reference levels. And how do we use diagnostic reference levels to optimize dose? So we send off the data, all that data, Dr. Panru Thai and her team, they've established Thai national DRLs. And now those numbers are going to come back to the hospital. And those values we're going to use in our optimization team to try to decide what we should do to make an informed decision on what we do. Do we reduce our dose? Maybe in some cases we increase our dose because then they were too low. And so the DRLs help us standardize what is a quote unquote acceptable level of radiation. And so if we establish the national DRL for a routine brain, let's just say it's 35, let's say it's 40 CTDI. The volume CTDI is 40 milligrays. I just picked that number. I don't exactly remember what it was when we looked at it 2 weeks ago. But let's just assume it's 40. And you look at your data at your hospital, and if you're above or below that, you need to now make a decision on what we do with that optimization. The fact that the 40 value was set, that just says that 75% of all of the hospitals that provided data in this calculation, so 75% of the hospitals in Thailand are imaging at that value or below. And so if you're above that value, you have to ask yourself, is there a reason why I am above that value? If there is a reason, then you're okay. But if there is not a good reason, a good justification, then we know we can lower it. And that becomes this idea of moving all of the Thai data or imaging towards an acceptably lower level. And this will help us understand kind of how we do things and we use our imaging on a day-to-day basis. But the question I had from the very beginning, we talked about risk. At the first week, we talked about radiation dose risk. And in Thailand, for example, your natural background radiation is very, very low. And therefore, the amount of radiation your population, the type of radiation your population is most exposed to is actually from medical imaging. So what is the total dose burden from imaging to the Thai population? And so that's something that I would challenge you, as now you've established DRLs and you're starting to roll out this new technology, the dose monitoring software, you're going to get to the point where you can collect a lot of data very quickly. And I want to show you some examples of how we do it here, of course, in the US. Every country does it a little differently. But what we've been doing for the last really couple decades is we have been doing surveys where we look at the total population survey for medical imaging. And there have been 2 publications of this data. So the first was in 2006. So basically they looked at data from late 1990s up to, I think, 2004, 2005. And that's what the data is in the left side. And then from 2006 to about 2014, they collected that data and then they published it in 2016. And that's what the data is here. And so you can see in up to 2006, we acquired in the US 377 million exams, medical imaging exams. And it broke down by mostly 281 were planar radiography and fluoroscopy. CT, which of course is what we're talking about here, accounted for 62 million. Now fast forward 1 decade, and here you can see CT usage is up 74 million, up from 62. The total amount of imaging actually decreased by 7 million. So CT went up, total went down, so therefore other areas like radiography, fluoroscopy, nuclear medicine, other areas have decreased. This is helpful because not only does it tell us what we're imaging, or excuse me, what type of modality we're using to image mostly. So when it comes to doing optimization of radiation dose and image quality, you get an idea of where you should focus your efforts. Obviously, CT is increasing, and maybe, for example, nuclear medicine is decreasing. But you can now look at the total dose burden to the population. So on the left-hand side, the radiation dose burden for kids being imaged, 84% comes from CT. And so if I want to make a positive change for the amount of radiation we use when we image kids, changing something in fluoroscopy or nuclear medicine doesn't make as big a difference. But if I make a small change, albeit small in CT, I'm going to affect 84% of my pediatric population. Now compare that to the adult plus pediatric population. CT is actually only a smaller chunk of that. We still do a whole lot of just planar radiography and fluoroscopy in the adult world. Even though we do a lot, don't get me wrong, we do a lot of x-rays and fluoroscopy in kids, but they just account for a very, very small amount of the radiation dose. Whoops. All right, so when you look at the dose here, oh, I'm sorry, I actually misspoke. I said dose burden. My sincere apologies. This isn't dose burden, this is usage. In kids, no, I'm sorry. I'm all confused. My apologies. What I said was correct. This is dose burden. 84% of the radiation dose in kids comes from CT. When you look at kind of the adults, so this is adults total population dose. So this is kids and adults. When you look a decade ago, we were about 3 millisieverts, and 50% of that came from CT. If you go forward to 2016, the dose burden has actually decreased. We've gone from almost 3 to just a little over 2. And even in that time, the usage of CT has gone up. And a big part of that is what we're going to talk about today, of all of the positive optimization that we have done, like we've talked about already in the last hour, and we will now talk about now. All of those efforts that have been put into place for about a decade have paid a huge dividend, have reduced the overall population dose, even though we're using imaging more. So one would argue we're imaging safer now. Here's just a breakdown of the CT of once again here in the US, but brain imaging only accounts for a little less than 20% compared to, abdomen pelvis, which is 26%, chest is roughly 16%, head and neck is about 10%. And when you look at the overall dose per exam, brain is right here, a little less than 6%. It's this blue chunk right here. So about 20% of all CTs in our total population are brains, but they only account for less than 6% of the dose. And part of that is because the anatomy that we have up here is not as radiosensitive. The brain, our glands, and our eye lenses were probably the most radiosensitive. But besides that, it's just muscle and a little bit of fat, and there's not a lot going on for us. But most of the radiosensitive anatomy is down here, especially in the chest and thorax, but definitely in the chest, abdomen, pelvis area. And so that's why when you look at the overall dose burden, 26% of the scans in CT are for the abdomen, pelvis, but the dose burden here is 38%. In chest, we do about 16%, and here it's 18% dose burden. So when we look at the chest, abdomen, pelvis, that is a big chunk of the dose pie over here, which we'll talk about next week. So it's important to know kind of that proportion. We do a lot of brain imaging, but it doesn't as much affect the overall total dose. So brain plus head and neck, 28% of all total imaging, but only accounts for less than 10% of the dose population. So it's important that we optimize brain imaging because the radiologists need to see what they need to see to make their diagnoses. But do we need to worry about it as much for risk? No, we could probably focus a little bit more on the abdomen pelvis if we're looking at it purely from a dose perspective. All right. That's basically what I just said. So I mentioned in the last decade, at least here in the US, well, let me step back. So why did I go through this process? This is US data. I'm talking to my friends here and the Indochina Peninsula. And you guys, I strongly recommend that this is a direction that Thailand and everyone listening goes. As you now have established dose diagnostic reference levels, the next big step is to understand the overall burden. Well, burden is probably the wrong word. Usage or utilization. So how much is going to CT versus planar radiography and mammography and fluoroscopy? That's one type of study. And then the next study is the overall dosing that goes into that. And so it's wonderful that you guys are getting the new technology. You're going to get radiometrics. It's going to be widely distributed throughout Thailand. And as you then start collecting that data on the national level, I strongly recommend, and I hope one day we'll get to see all those types of pie charts, because it then helps you understand where best to focus your optimization efforts to make the biggest, as we say, bang for your buck. You want to make the biggest change that can cause the greatest good to happen for your population. All right, so, excuse me. We talked about how image quality, we talked about how when new technology comes out, we should constantly be reassessing for image correcting for and using that new technology for improving image quality and potentially reducing radiation dose where impossible. And I demonstrated that over the last 10 years, we in the US have been using more, we've been acquiring more CT scans in our medical population than we did a decade before. And we've been doing it at lower doses. And it's all because of, and this is, I think it all just encapsulates it in this one slide here. You see on the left side here, the first clinical CT scanner developed by Dr. Hounsfield. And it only scanned the brain. So it's actually quite interesting that we're talking about the brain today as the first modality of choice. And it's not even the whole head. We couldn't do face imaging. They couldn't do facial imaging. Definitely couldn't do neck. It was quite literally just the top of the head. It was the cranium. This is the first clinical scan of a human. And you can see that it was, is for as low a quality as it was, it still got the job done. You could still see that there was something there. And so you could diagnose the disease in it. Ironically, it took 4 minutes to acquire the scan, and it took 24 hours to reconstruct it. And there was no such thing as CTDI. There was really no idea of how to determine how much radiation they used. Fast forward to this year. This is just an image I took off of PACS. And I've already shown you several images from this patient in my previous talk. This was acquired in 0.275 seconds. The reconstruction time took less than 30 seconds, and it had a volume CTDI of 25 milligray. So we had an idea to understand about how much dose it got. The quality obviously is just, there's no comparison. It's infinitely better. And so the concept here is technology will drive better image quality improvements and lower doses. And so we constantly need to take that image quality, that new technology that comes out, and constantly invest in it. And so if you're using a CT scanner, which I don't even know if you can, but if you're using a CT scanner that's 15, 20 years old, you're not doing a service to your patients. You really do need to do your best to try to keep the newer technology. Now, I know there's a lot of reasons why not every hospital can afford the latest and greatest CT scanner, or they just don't have the patient population that needs a lot of scanning. So there are a lot of other factors beyond just getting the best image quality. But as an optimization team, radiologists, physicists, technologists, and our IT friends, we have the opportunity to hopefully talk to and help influence the hospital to make the right decision when it comes to buying new scanners with the latest and greatest and best technology. All right, so we're going to talk a little about applying diagnostic reference levels to patient monitoring today. So just a quick review. I know I've already talked about this, but I'm going to talk about it every week as we look at the various different modalities, just as a refresher and as a reminder. So what are not DRLs? How should we not use it? Well, they're not to be applied to individual patients. So you scan a patient, it has a CTDI vol of 25 milligray. You can't necessarily compare that value to the DRL. And there's a reason for that. We've talked about it, but you're not supposed to just make that direct comparison. They're not to be used as a limit for the amount of radiation we use to acquire patient examinations. So what I'm saying is you don't get the DRL and say no one can ever go beyond that. That is not actually what a DRL means or is to be used for. It's not to be used for regulatory purposes where the government comes in and says nothing over this level. And it should not be used to penalize a hospital. So if a radiation dose is above the DRL, there may be a reason for that. But it should never be punitive where if a hospital, is imaging over that value, that there is some kind of penalty that is applied. How should we use it? Well, it's an optimization tool, and I'm going to give you examples of that today. It defines a level or helps us define a level. Remember, I say it's like a line in the sand. It's a point where we say, okay, if we're over that line, we should look at things. We should investigate. It's simply meant to be a test, and it's helping us find unusually high values or unusually low values. And we already know, but what is a DRL? It is the 75th percentile or the third quartile of nationally acquired data. It's not only nationally acquired, but it's vetted. We talked quite a bit about getting rid of the outliers on the low and the high side. And we talked about the proper ways to make those calculations. But once you get good data you've looked at the distribution and everything looks good, the value at the 75th percentile is the national DRL, can be applied as the national DRL. And then the second value is at the median, the 50th percentile. And that is what we consider the achievable dose. If everyone is imaging at or below, not everyone, but if the majority of people are imaging at or below 75th percentile, 75% of all the hospitals, that's a good thing. But there are still 50% of the hospitals that are imaging at this value, the median. And so the goal would be that if you are at the 75th percentile, maybe you can lower yourself down to the 50th percentile. And that's why we call it the achievable value. And I'm going to give another example of that today. And what are the values that we should use to calculate or to track for DRLs? We talked quite a bit about the volume CTDI and the DLP, and that is what you guys have done. In Thai, you have national DRL values established around these two. There are also opportunities to use SSDE, probably not now, but definitely going forward, SSDE I think is going to be a very important metric. And the big thing that will change is currently on all CT scanners, it is required to display the volume CTDI and the DLP. The IEC, which is an international body that helps regulate and all of the various vendors of the CT scanners, they're the ones that come up with the standards that each of the vendors must meet so they can build and sell their scanners. They've just approved and are now requiring that SSDE will be displayed on all CT scanners. So now you will see CTDI, DLP, and eventually with the newer CT scanners in the next probably year or two, you'll start to see SSDE. So going forward, there will be a need for a national DRL, probably with SSD. But we can argue and we can talk about that at a different time. Effective dose is not appropriate and organ dose is not appropriate, as we've discussed. It is important to point out that the IAEA and some international journals have started calling the volume CTDI the volumetric error Kerma index, or CVOL. And they've started calling the dose length product, they're now calling it the error Kerma length product, or P sub KL. It's just important to point that out. What you choose to use, the definition, the title, the wording, that's really on you. Obviously, all the vendors still use volume CTDI and DLP. We here in the US still use these terms also, and Europe also uses them. But like I mentioned, the IAEA has started using these terms, and there's a reason for that. That's beyond the scope of this conversation. We can talk about it another time if you do want to know that. I can say, as someone that sits on the IAC for CT, on the CT committee, they have not moved towards adopting these values. So I don't think you will see these values anytime soon displayed on your CT scanner. So staying with or continually using volume CTDI and DLP is a very safe and a perfectly appropriate thing to do. All right, so which predictor should we use? Obviously the volume CTDI. Why is it? It's great for optimizing scanner protocols. And it's good for setting alert levels when we're trying to track changes when we're imaging patient to patient. DLP is great for predicting the total energy imparted to the body. And that's obvious because, as we talked about, CTDI is simply the average value at the center of the scan field. So if this is my scan field, CTDI is the average value right in the middle of that. Whereas dose length product will tell you the overall estimate of dose imparted to that entire volume. And once again, it's also good for setting alerts to capture not only the overall output, MA and KV, which is what we use to calculate for CTDI, but it tells you the length. And so if you have one brain protocol and you're looking at it and you have a nice average distribution of dose length products, and one patient comes in and the value is so much higher than that, well, most likely the MA is fine and the KV is fine, but what's different? The length. And so dose length products are really good for helping us understand if we're doing all of the right things. We're not only setting the right MA, we're setting the right KV, but we're also making sure we're setting the right scan field of view. All right, and then SSDE, as we've talked about, the size-specific dose estimate is good because it helps us convert, or it helps us better use volume CTDI to predict actual dose burden to the patient. CTDI vol, that is a value that is, and this is why the IAEA started to adapt it, started calling it the error kerma, or the volumetric error kerma index, because the volume CTDI is a value that we calculate for the center of the scanner in air. It has nothing to do with humans. You could go scan a block of wood and it would have the same volume CTDI as a human would. But when you start doing SSDE, it starts to take into account the attenuation differences of size differences of the patient. And so it gives us a better estimate for what the actual patient would get if we calculated patient dose. All right, effective dose, we already know this, we've talked about it, but it's not patient specific and it should not be used for alert levels. It is, though, really good if your total optimization program is looking at making, optimizing fluoroscopy, radiography, CT, nuclear medicine. But if you calculate the patient population exposures in each of these modalities, each of those modalities have their own dose metrics: error kerma, CAP, volume CTDI, DLP, millicuries per kilogram. All of these metrics, they're so much different. But if you can calculate them all, if you can convert them all to effective dose, then you actually have a way to compare dose output for each modality. So not good for alert levels, but great if you're just trying to do overall comparisons. And then organ dose is definitely not great for diagnostic reference levels, or setting, doing that kind of stuff. Frankly, we can't even really do organ dose calculations yet real well, but they are the future. And everyone is working towards this idea of being able to do auto organ contouring on every CT scan so that we can do dose prediction per organ. And that, once again, is its own talk, and I won't get into this, but we always talk about what is the risk to the patient when it comes to CT scanning. We don't know what the risk is because we don't actually have patient data. We have machine output data, volume CTDI, DLP. We have better approximations such as SSDE, but until we can actually start calculating true organ dose for each patient on each scan, we really will never get to an idea of what is true risk. And so organ dose calculations are great for the future. They're a research tool at this point, and they will be a wonderful way for us to understand true population dosimetry, but definitely not a good tool for diagnostic reference levels. So as I mentioned, what we've done now, you have done now in Thailand, is you've created these national DRLs. And so at the local level, you, the hospital, will take your values, you'll calculate the median dose. This is why it's not a patient-specific value, but you'll take the median, say let's look at 100, 200, 2,000 brain scans, face scans, neck scans, whatever it is you're trying to optimize. And then you get the median of that value, and then you compare that to the national DRL. And this will help us know what we're going to optimize and where, we should optimize. And then just as a reminder, I showed this slide last week, or 2 weeks ago, I should say, you need to know that the value you're using to compare at the hospital to your national DRLs is a good value. It's accurate. And so you need to be constantly checking, for example, the volume CTDI to make sure it is accurate. And the only way to do that is to test it with a standard. And so you can use a CTDI phantom with an ion chamber. You place it inside your CT scanner, and your physicists there are going to verify that the value listed on the CT scanner and the value that is recorded with every patient examination is accurate. And so you want to have faith in the numbers that you have. Good data will give you good results. If all of your CTDI numbers are completely wrong, how do you optimize? And so checking those periodically, at least once a year, is a wonderful way to make sure you know, or your team knows, what to do. So we talked about this already, but when we talk about radiation dose optimization, it is also a team effort. So going back to this chart, this interconnected web chart, we were a moment ago talking image quality, about an hour ago. And now let's focus on the dose side. When you can see here, this dose side, this yellow box, it actually points to only points to a very few amount of parameters to affect. And so there are small features for us to optimize. That's actually a good thing. It makes our task not as complicated. But whoops. Sorry, pushed the wrong one. It's important to notice that not all the features directly affect image quality. And so if you look at it, this radiation dose value obviously is affected by changing any one of these things, like tube current, tube voltage, rotation time, pitch. Well, we'll explain that in a minute, but any one of these terms, factors right here, will affect the output, radiation output. But radiation dose right here, as you can see, as I draw this line back, it goes back to one of the other higher level optimizations that we're trying to take into account, risk. And so when we deal with risk, we also have to take into account some of the other factors like patient age, sex, etc. And so radiation dose initially, is directly connected to these things, and obviously the patient parameters. You can see these lines right here as they go up to height, weight. Obviously the patient size will affect the radiation dose. And then the other thing, sorry, I keep pushing the button and I'm trying to use my mouse as a pointer. There we go. Radiation dose, you can see, has as it points to all of these parameters here. As we talked about last time, these parameters also point to image quality. So radiation dose, as we change the radiation dose knob, it's going to have effect of risk, as I was just talking about a minute ago, and image quality. All right. It should be pointed out, though, it's not really appropriate for this talk, but this idea of appropriateness, I think, is probably one of the best ways to reduce patient radiation risk. Is the imaging appropriate? Is the task necessary? And if it is, then obviously the next step is to make sure we got the right image quality and the right dose. But if it's not appropriate, then removing the need to make those images or to scan those patients really reduces the amount of radiation dose we give to our patients, because we're taking that away. And it obviously completely reduces the risk to that patient. So not part of today's discussion, but I think it's always very important for us to constantly look at the appropriateness of all of our protocols and the reasoning for why they're ordered. And once we know and have and we believe that they are appropriate as they've been ordered, then the next goal is to maximize the benefit to risk ratio. All right, so The first steps in dose optimization and establishing what I would say, quote unquote, is appropriateness is setting specific guidelines for ordering CT. And so I'm just going to give you this example. This is something that we do here in the US. I imagine you guys do this. You probably have something equivalent to this in Thailand. But head CTs are one of the most commonly ordered CT exams for the kids. I showed you that in those pie charts. And so there is an organization here in the US called the Pediatric Emergency Care Applied Research Network, or PECARN for short. And what they did is they went in and they looked at when is it appropriate to use a CT to scan for traumatic brain injury. And they basically said that if they meet very specific criterion, then yes, scan. But if they do not meet those specific criterion, that there really is never a reason why we should CT scan. And then in many cases, even if they meet some of the criteria, but not all of them, then we can still observe the patient, and that might be sufficient instead of needing to CT scan them. So they came up with, the PCARN came up with this flow chart. And so I'm just going to walk you through an example of this as you can see how they established this idea of appropriateness for using CT. And it's all based off of the Glasgow Coma Scale, or the GCS. And so if you have a GCS score of somewhere between 14 and 15, and I should also mention it's been divided into, if a patient's less than 2 years, you use this flow chart. And if they're 2 years or older, you use this flow chart. So I'll just use the example of a patient that presents 1 year old, and they have a GCS, let's say it's 14. And if they have other signs of, say, altered mental status or palpable skull fracture, then yes, it's probably okay for them to get a CT. But when you consider the total population for folks with GCS of 14, altered mental state, and palpable skull fracture, that only really accounts for about 14% of the total population. And when you consider the clinically important traumatic brain injury, or the CITBI, that really only accounts for about 4%. Now, if the patient has it doesn't have this set of criteria, then you need to ask the next question. Well, is there an occipitoparietal or scalp? So if there's a scalp injury, a hematoma, if there's a visual effect beyond just maybe palpable skull fracture, if there's a history of loss of conscience or severe mechanisms of injury, maybe they're just not acting normal, then if that's the case, then beyond these original criteria, then yes, we should order a CT. And in this case, now more of the population falls under this umbrella, about 33%. But still, the potential for risk is fairly low. And so in this case, really, they give some more criteria saying you could still probably observe these patients unless maybe, for example, they're less than 3 months, or the physician isn't as comfortable, and so they just want the CT scan to rule out. But if they don't have these initial criteria of GCS score 14, etc., and they don't really have scalp problems or damage, or they haven't had a loss of conscience, then the answer is no, a CT is not recommended. And when you look at the total population, generally speaking, 53% of kids that present where they are being observed for TBI, for traumatic brain injury, 53% of them don't need a CT scan. And it's just because if you look at all the various different criteria, they don't quite meet all of these. And so if they just simply observe the patient, and as long as the patient, there's no altered state or nothing happens, then the patient can eventually go home, or, go on to other different clinical indicators. And so setting up an idea of when to CT scan is probably, like as I've already said this once, I'll say it again, is probably one of the best ways to reduce, quote unquote, reduce radiation dose to kids, but even adults. And so setting up that level, and that's probably more, that's maybe higher than the dose optimization team. That might be something where you need to really bring in the leadership of radiology and maybe other groups like pediatrics or surgery or a few other, the emergency room. They may be able to come together and help decide when we order and when we don't order. So, but having those discussions is a very important one. All right, the next step to considering for dose optimization is clinical indication. So we can actually optimize the dose based on what we're looking for. And so if we are looking at an inherently high contrast indication, so if we're looking at hydrocephalus, or shunt drain placement, these are clinical indications that most likely do not require a lot of radiation, because the image itself presents with an inherently large amount of radiation. So if there's a lot of noise in the image, you can still see maybe the overall extent of the hydrocephalus, and you can definitely see where the shunt is located and is it in the right location. And so you might not necessarily need a lot of radiation. Whereas if you're looking for subtle bleeds or low contrast tumor or something, then yeah, noise could obscure that, and so you would need to make obviously an appropriate adjustment to make sure the protocol is set up to acquire a little higher radiation dose in that regard. All right, so transitioning now. So we've talked appropriateness, we've talked about setting up protocols based on clinical indicators. Now let's get into kind of how do we set up the protocols for proper dose optimization? So Tanya mentioned this, and I'm just going to demonstrate through this with some data here. Our heads grow logarithmically. They grow logarithmically laterally and also craniocaudal. And so little kids will see a large amount of change in their overall head diameter in a very short amount of time of their lifespan. And then as time goes on, basically from 2 to 5 years old, we see very little change in our overall head size. And so that's actually a good thing, because we can use this knowledge here to establish how many protocols potentially we need to establish, because we definitely need to be able to account for imaging really small heads versus really big heads so the CT scanner can get the right dose. But the other thing is the overall density. And so here I just went through and placed a bunch of little ROIs and all this, which is not really easy because there's not a lot of anatomy to measure the CT number of the calvarium or the skull. But what you see is also the density of the bone. The bone ossification changes logarithmically over time. And so little kids have not as dense bone and not as ossified, and so we don't necessarily need as much radiation to image a little kid as we do older kids and adults, of course. So the first step here is, if the head is changing logarithmically in size, how many protocols should we use? I give you an example of how we do it here. We're a pediatric center, of course, but we chose to make a protocol that covers just 0 to 6 months. And why is that? But you can see the most change in the head diameter is in those first 6 months. And then the next one would be 7 to 24 months. And forgive me, I didn't put a line here for 0 to 6 months because there's really no way to put a line right there. So the next line here, what I'm showing you is basically up to 1 year to 24, 2 years, 7 to 20. Yeah. Whoops, my lines. Okay, I'm sorry, my lines are off here. That was 0 to 6 months. And then 7 months to 24 months was this line right here, which, as you can see, is the next biggest change in the anatomy. And then this 1 to 2, that's a mistake. And then the next one is 2 to 5, up to through 5 years, so up to 6 years, and then everything beyond that. So the most change happens at that really young age, and then there's the next one down here. But as we get a little older, basically after 2 years old, there's not a lot of change in our overall diameter of our head. And then, as I mentioned, skull density matters, all matures logarithmically too. And so as we set the proper techniques, one of the most important ones in the head is setting the right tube potential, or the KV. And that's because the KV helps drive the penetration. If we have an energetic photon, it's going to be able to get through our thicker skulls, our more dense skulls. And so generally after the age 2, we're still typically imaging at about 120 kV. Now, every vendor is going to have their own settings. Some may be able to, some may allow you to set something besides 120, but generally speaking, after 2 years old, you're imaging at 120 kV. Now, the caveat to that is you really get better gray-white differentiation, better contrast at 100 or less kV. The higher the kV, the less or the lower the contrast, inherent contrast in the image. And so in a perfect world, we'd really like to image using 100 kV. But that's why we set, that's why we set several protocols, 5 of them up, so that we can actually image several of them at 100 kV for the little kids, and then a couple and the rest at 120. We talked quite a bit about this, so I won't belabor this point, but fast imaging is really good, especially helps to minimize motion artifacts. And so how do we do that? Well, you have those high pitch, fast, so the high pitch, large beam width, fast acquisitions if you're doing helical. And I give you an example. If you have a Siemens scanner, they have what's called a flash mode. Or you use those wide volumetric coverages, such as GE and Canon. And where I've indicated almost all patients, their overall patient, the length of the scan, say craniocaudal, almost all patients would fit within a single rotation axial if you have the ability to image out to 16 centimeters. All right, so the other thing to consider when we're optimizing dose is we talked about how the anatomy in the head is not as sensitive compared to, say, lung, breast, stomach, colon, everything from the neck down. But the eye lens is actually, and so we will have to be careful. Too much exposure to the eyes can induce cataracts. And so that is the principal reason why we angle our CT scanner to try to image we're imaging the cerebrum, but we're doing our best to not directly image over the eye. Now, there's 2 ways to do that. Obviously, there's the physically angling the CT scanner. Not all CT scanners can physically be tilted. There are a couple of out there, specifically the GE scanner, the Revolution, the Apex, they're bolted to the ground. They don't tilt. And so, and all vendors do this now, but there has been a development of using what's called organ dose modulation. So just like tube current modulation, as it rotates around the body, it can change MA for thin areas of the body and thicker areas. But organ dose modulation gives us the opportunity, as the X-ray beam sweeps anterior over the body, there will be a point where it's covering or it's sweeping over the eyes, and it will automatically reduce the MA over this arc compared to all of the rest of the sweep. And it can also be applied down in the body. And of course, that arc will be a lot greater because in this case, now we're really trying to reduce the dose, for example, to breast tissue. But up in the head, our eyes, and down in the neck, our thyroid, those are kind of the more sensitive ones. So if we turn on organ dose modulation, here you can see this is a piece of film that I cut and I sandwiched between 2 CTDI phantoms. And then I imaged it with organ dose modulation off. And the dose is, for all intents and purposes, homogeneous in the volume. You're going to have a little less radiation at the dead center. That's because of attenuation. But for all intents and purposes, you get this, the yellow is pretty much the same around the edge, and it's just a little lower in the middle. Now, when I turn organ dose modulation on, I've actually reduced the overall radiation dose to this anterior sweep by about 25 to 30%. And then the radiation dose is going to be obviously higher around it compared to the center or to the anterior sweep. There is one vendor out there, almost all vendors, when it passes anterior, it reduces the MA, but then as it keeps going, it goes back to normal. There's one vendor that reduces the MA here, and then it turns the MA higher over here. So the total MA is the same in the center, but that means that some of it is a little higher down here. Others, like I said, they just reduce the MA up here, and so the total value is actually a little lower. Now, the question you would ask is, if it's going to reduce the MA as it sweeps over the anterior aspect of the body, is it going to change the image quality? Are the more anterior portions of our anatomy going to be noisier? Because obviously you have less MA. So the answer is, no. This was a cadaver that we scanned, and we asked that question. Does tube current modulation plus organ dose modulation reduce the image quality compared to here? Now, one may argue that it is slightly more noisy, for example, here in the orbit. And the answer is, when you draw the ROI, the Hounsfield unit, the noise is 4 Hounsfield units here, and over here it's 4 Hounsfield units. So metric-wise, mathematically-wise, it isn't. Visually, you could probably say it's just a little bit, but it's been in our practice of using this, we've never really, the radiologists have never ever complained, and they've never ever said anything negative about it. And so I think the change is depending on maybe your sensitivity as a radiologist. It's hard to say that you'd really see a difference, but you may. All right, so those are kind of a couple of the different aspects in which you can, different ways to apply dose optimization when we're talking about imaging in the brain. So I'm going to give 2 examples of now how we apply the DRLs to our own personal hospital data, and how we can set alert levels so that you can, as an optimization team, know where to operate and how to make the biggest impact. So I'm going to give 2 examples. The first example, of course, was going to be my data from Cincinnati Children's. And what you're going to see here is for over a couple of years, over 2 years, I looked at about 4,000 scans, and I looked at brain CTs with and without, so 2-phase CTs. As I mentioned, we actually have 5 now, but previously we only had 4. 0, 6, 24. Yeah, there's one missing right here. Yep, there's one missing right here, 7 to 24. So there should be 5, but yeah. So there should be 5. Back in the day, we only had 4. So I guess I'll just say that much. And that's why you see 4 different colors. And the dosing, you can see, is slightly different. So our little guys, they just didn't need as much radiation. You know, like I said, their skulls aren't as dense, so we can get away with using 100 kV, maybe a little lower MA, compared to our over 13-year-olds or our quote-unquote adults, dope protocol that does require a little bit more radiation, definitely at a higher kV to penetrate the skull. So the first thing you can do when you look at this data, oh, and I should also point out, we used fixed MA, which is obviously apparent to you because the data is a flat line. It is horizontal. If you use tube current modulation, you would see a lot more of a scatter. But we just personally use fixed MA for a variety of different reasons. So the first thing I can do is I go to our national dose reference level, and I can look at all our data compared to the national DRL. So here in the US, the national DRL volume CTDI is 60 milligray. And the achievable dose is 50 milligray right here. Now, it's worth pointing out that at least here in the US, those values are not pediatric specific. They're all adult specific. And we here at Cincinnati Children's, we looked at about 500,000 data points across the nation. So not just our data here at Cincinnati Children's, but at all the hospitals that image kids. They're either children's hospitals, which are these blue and purple ones, or quote, adult hospitals that image kids, which are the red and orange ones up here. And so what we did now is looking at just kind of the average. Remember, the DRL is the 75th percentile, so it's the top of all the boxes. So if you look at all of the box tops and you kind of take an average, which you just have to take my word for it, that's basically this solid line right here. And then the 50 percentile is this black line, that median, the middle point. If you take an average all those, well, that's kind of basically right here, 36. And there's your volume, CTDI, and DLP. So this value, this 46, is actually a lot lower than the 60 up here, which is for the adults. But what I now am going to do is I'm going to take, there we go, and I'm going to put I put this little tilde here, this approximate, because they're not actual national DRLs anymore. This is just data I acquired it was national data, but it's not been sanctioned as a national DRL. And so I apply that to our data here to just look at things. So once again, the 75th percentile of the data you saw on the previous slide, all of our values are below that. And then when I apply that the 50th percentile, the achievable dose, potentially achievable dose for pediatrics, it is, for all intents and purposes, most of our data is below that, but there are some data points that every so often will just kind of pop up above it. So because everything is below the national DRL, or in this case, the pseudo national DRL, maybe we don't need to reduce the dose in our patients population. So what we need to do when we investigate this is we need to ask ourselves, is there a reason, is the image quality appropriate for the task? You know, for the appropriateness, for the clinical indication, is the image quality appropriate for what's being done? And from that, we can set alert levels. So whenever so often a little dot will pop up above this alert level outside of the trend of what we expected, then we as an optimization team know what to do or where to look to start our investigation. So by setting the alert level here at what we ended up doing is if you set the alert level at the achievable dose, obviously we're going to get a few patients that'll cause the alert level to go off. What we ended up doing is we set it at 115% of the value of this national achievable dose value. And so that was basically 40 milligray. And so if you look at our alert level is basically at this 40 milligray level. And basically over 2 years, that accounted for only 7 alerts. And so generally speaking, most of our data isn't causing an alert, but we wanted to set a value that when something comes up above that alert level, it's obviously much higher. It's 115% higher than that achievable dose level. And it's definitely higher, obviously, than our what the value we expect it to be. So here's an example. I drew a little circle around it. What caused this patient examination to cause a value to be above 40 milligray when the expected value was basically 35 milligray, this green line. So we looked at it as a dose optimization team, and we found out that this patient received a routine head CT and a CTA, so a combo of 2 scans. The routine head CT, so when we looked at it, it actually had the correct 35 milligray dose. So what caused the alert to be triggered? Well, it turns out that Radiometrics, whenever there's a combo, will take the two CTDIs and combine them. So the CTDI evolved for the routine and the CTA got added together. And it wasn't actually a perfect add, and so something was kind of weird with it. because the CTA is actually a little higher than only 10 milligray, but it caused the value to go from 35 up to basically 43. And so this was just a false alarm, 40.3, excuse me. So this was a false alarm. And so we still looked at it because it surpassed our alert value. And so what we needed to do is set the alert value, the threshold, and then as an optimization team, just constantly look at that. In most of our cases, in most of the cases that occur at our hospital, most of them are actually false alarms based on something that went wrong with the way Radiometrics combined the data. Now, I'm not trying to be negative towards Radiometrics. All dose monitoring software is going to have quirks, and not all of them are going to be perfect. And just every so often, one exam will maybe combine things in a weird way. But having that level, that alert level set, gives you as an optimization team a way to look at your data and know where to investigate. So now I'm going to expand this. I showed you, up to this point, I was showing you this data. 2018 data. I was showing you this data on this side over. So I was kind of showing you our good data. But what happens if I expand it and I go back further in time? And now you see all the way back to 2015, we actually had some pretty high values. Our average greater than 13-year-old and our average 6 to 12-year-old protocols were above what it would, quote unquote, call a pediatric DRL. And so when this occurs, when you actually draw that line, the DRL line, and then you start looking at your protocols above and protocols below, we realized we didn't feel comfortable with that. We looked at the image quality and we realized there's good image quality. Obviously, everyone's happy with that. But could we do as well below this line? So what we did is we decided to make several interventions. We ultimately ended up doing 6 interventions. Every time, what we did is we reduced the dose by 5%. So that's why you see this step, and then a step, and then a step, and then a step, and a step, and a step. We just kept stepping it down. And every time we would reduce it by 5%, we would give it several months, and then we would collect data, and we would ask ourselves, and so if we collect data for a month or two, and then we ask ourselves, we look at the image quality, and we asked the radiologists, how are they comfortable to do a quick survey? Everyone was happy, everything's good. We determined the image quality is fine, looking at phantoms and doing the physics test. We would dial it down by 5% again, and again, and again. And eventually we got to the point where we dialed it down. You actually see there's only 5 lines here, is because we actually did 6 interventions, but we realized that 6th one was a little too far. And so we dialed it back really quick. And so that is how we found our sweet spot. We're happy with the dose, and we're happy with the image quality, and the ultimate reduction is we got about 35% total patient population dose reduction, and the net effect is our new values for the greater than 13-year-olds and our 6 to 12-year-olds. They're definitely below the DRL, and they're also now below the achievable dose. And so, and everything else reduced also as well. So at every step, we reduce the dose, which is a good thing, but at every step, we were always investigating image quality, making sure that the radiologist got the right image quality to be able to do the right thing, and so they could do their diagnosis. Obviously, some key points here. As pediatrics, you need more than one alert level. So when you get your national DRLs back, that's wonderful. But a national DRL, I'll just flip back one screen. A national DRL right here may make it made a difference on these 2 protocols. But as you can see, even our little guys, our protocols for the littlest guys decreased. So we didn't just change what we saw in these ones, which were over. We chose to change the entire protocol, which was for clinical routine heads. And so even the little guys got a image quality and dose reduction. But if you set one alert level, it's hard because it'll only ever trigger for your adults or your large kids. It would never, ever, ever trigger for these little guys, these less than 6 months. But yet, look at this. There's this weird little clumping of data right here. Sometime kind of in the early to mid 2018, our things were going crazy right here. And what ended up happening is we were having some issues with those protocols, some software reloading and loading, some other issues that only affected this protocol. And so if you have an alert level that's set all the way up here, you will never see this problem. But if you have multiple alert levels, if you have multiple protocols, then you can even catch these weird subtle issues. And once you have your new tech software, your Bear or your Radiometrics, setting multiple alert levels is really easy. And then you'll just get an email every so often when something goes above that alert level. All right, and that's kind of what I said basically. You don't want to set the alert level so high that nothing ever triggers it. But if you set it too low and it triggers every day, well, first of all, you'll just, like I said, up to this point in our experience, most of them are false alarms. So if it's triggering every day and the preponderance of them are false alarms, at some point, human nature is just to start ignoring them. And that's not appropriate. And so you got to find the right place. You have to look at your data. You need to go in, do an average of your data. Especially it'll be helpful once you got Radiometrics. If you don't have that, you can still do a quick survey of your data. And then from PACS or from your CT scanner. And from that, you can then select your alert levels. All right, second example, maybe something a little closer to your home. In Japan, back in 2016, they had several hospitals that were doing routine head exams. This is for adults, non-contrast adult brain imaging. And they just took the data and they wanted to apply it compare it to their national DRLs. And these values, milligram per centimeter, this is the dose length product. So not volume CTDI, but these are DLPs. And here you can see for several protocols that used a helical acquisition, the values were much higher, statistically significantly higher than the national DRL compared to their old the conventional axial imaging that they did over here. So what did they do? As an example of what you can do also, they went immediately to their phantoms. This is a CAT phantom, and they imaged it. And this is the low contrast module. So you have all these various different contrast level, these little circles, the diameters change at different locations in the phantom. And as they imaged it at different dose values, and they compared the conventional to what they proposed as a dose reduction. And what they found was and here you can see where they placed their little green ROIs. What they found was the dose reduced images did not reduce object conspicuity. So they felt comfortable by doing this quick study, well, not quick, but doing this thorough study in the phantom, that if they made the same change in the patient population, that there wouldn't be an adverse effect, and that the image quality would still be okay at a dose reduced level. So here you can see they acquired data for some time before the intervention. They made a change to the protocol. And then after that, they looked at the same patients. And they had, I'm not going to go into the details. They asked a couple of radiologists to rate some images, and they had a variety of different questions and different. But the point here, all I'm trying to make is, even though they looked at 4 different metrics, you can see that the overall magnitude of each of these colors stayed the same before and after the intervention. In other words, the image quality before the change and the image quality after the change stayed the same. And this is actually a great example of subjective quality scores. As I mentioned at the end of my last the last hour, there's really three ways to do this. There's the reader observer, or the subjective quality scoring. There's the mathematical reader observer, which if you can, go for it. And then there's at the minimum, which is none of this, what you're seeing here. It is at least the radiologist sitting at the CT scanner, making sure when the scan happens, the image looks good, or they're in the reading room, just paying attention to these as they come across. In this case, if you read the paper, the Japanese paper, they actually had their radiologist champion who was in charge of making this change. When they went live, that individual actually stood in the CT room. When the patient got scanned, the individual, the radiologist, actually looked at the images on the console just to make sure that they looked okay. He or she didn't do a reading, didn't do an actual diagnosis, but just made sure the quality was okay. All right. So in conclusion, so the we talked about, I talked about and suggested doing a survey. So as you get the technology and the ability, the radiometrics and all that installed in Thailand, the next real big step after you've established your DRLs is to understand how you're using, obviously CT, but all of your other imaging modalities. We talked about various different dose reduction strategies. We talked about the appropriateness, establishing appropriateness criteria. We talked about how you can set different dose levels based on clinical indication. And then as a pediatric center, I recommend setting up protocols based on patient age. That said, for adult imaging, you probably only need maybe one protocol. Maybe if for whatever reason you feel like you have, when you survey your patient population, maybe there is more of the logarithm is maybe a little bit more steep for some of your adults. And so then you maybe have two. But for the most part, I would say you need one protocol for the adult population. And then for if you're imaging in the pediatric world, for the little kids, for 0 to 6 months, 6 months to 2 years, you definitely need one or two, maybe three protocols at the very early years of the patient life. And the reason for that is because the younger kids, you can image their heads with 100 kV or lower. And that's a good thing because it gives you better contrast between gray and white, especially because the brain, for the kids' brains, tend to be a little bit more water-based. And so they do not have an inherently a lot of natural contrast. And so you really need to use lower kV to really make the two tissues, the parenchyma, separate. And so you can see them, the gray and the white, etc. Whereas after they matured, their brains aren't as water-based. The parenchyma is not as water-based. After 2 years old, the skull is, for all intents and purposes, more ossified and almost as ossified as an adult. Then in that case, you do need a more penetrating radiation using 120 kV, roughly, right around there. And so that's why it's helpful to set up multiple protocols based on patient demographics. Obviously, it's important, if we can, to image as fast as possible using volumetric imaging or high pitch, high bandwidth, the largest, not bandwidth, excuse me, scan width for pitch, for helical acquisitions. And then, of course, we want to minimize radiation doses where impossible to the more sensitive aspects of the head, in the head, which would be the eye lens. So using organ dose modulation. If you have that as an option on your CT scanners, I recommend just turning it on. It's been my personal experience that just simply turning it on really does not affect image quality. If for whatever reasons you're CT scanning to look at the eye, then maybe you wouldn't, but even then you're most of the time looking for objects or trauma. So you'd still be able to make a good diagnosis. We've never had any issues using organ dose modulation to reduce the dose to the eye. It's great because it does reduce the dose roughly by about 30% to the eye lens. All right, we reviewed DRL implementation strategies. I gave you two examples on how we looked at our values here in the US and then how the Japanese, at least in that one study, looked at theirs. And then the way they approached it, we did ours at a stepwise process, just a little bit here, a little bit there. And at every step, we reviewed the results with radiologists. In the Japanese, they used a phantom to establish the initial change, and then they made an intervention and made a change, and then they were okay. So they only made one change, and they just went all in on that one change. Either way is perfectly fine. But in both cases, just worth pointing out, in both cases, there was always a clinical assessment. And I think that's really important. That's part of that whole optimization team. You need to have a radiologist there with you so that they are the ones that have the eyes for what they need to see in the clinic. And we, the medical physicists, the technologists, even the IT PACS people, we're here to help them do their job. And so everything we've talked about, image quality optimization, dose optimization, all of that doesn't mean a thing if the radiologist looks at the image and they cannot they don't have diagnostic confidence. So that's the end of my second talk, and I turn the time back to you, Tanya.
Thank you so much, Sam. I do agree. Yeah. So radiologists and I think like also technologists are the gatekeeper in terms of appropriateness criteria to suggest the clinician what they should order. Because couple times for me, I got a phone call from technologist and asked, yeah, doctor, I think the doctor, the ordering physician orders something, but I think it's inappropriate. What do you think? Can you confirm me this is correct or not? Should they do MRI instead of CT? So I think that helps us a lot. Yeah.
And I completely agree. And technologists, they don't get paid enough, right? They're doing so much work. They're working with the patients, they're working on the machines, and of course they're taking all the phone calls from angry doctors. And so we love our technologists. Technologists are the best. They really do make I mean, obviously we talk about setting the right parameters, right, to get the best image quality and the lowest dose. But if the technologist doesn't do it right, then it doesn't matter. And so our technologists are wonderful because day in and day out, the good quality scans that our radiologists they get to do their study is because we have technologists, that love their job and they are there to help the patient. So yeah, I love our technologists. They sometimes are the people we kind of talk about, radiologists, and we talk about physicists, but our technologies are right in the middle, and they're the most important part to get it all evenly flowing.
Yeah, I do agree. I cannot be a good radiologist without good technologists and good physicists to help me in that part. So I have a question, Sam, about the organ dose modulating technique that you mentioned. How does it work? I mean, because we know that for the dose modulating technique, it uses like the thickness of the patient. But for the organ dose, how it works? Because some organ is in the anterior portion, like a lens. Some of them like a thyroid, or maybe like in the body, is like a inside. It's not in the superficial. So how does it work? I mean, you just just push one button and okay, it's work.
Yep, That's it. It's one button. It really quite literally is that simple.
Yeah, but I mean, like, what is the rationale behind that? Things like the deep learning stuff that they know this is the organ that needs to reduce the dose, or
it's getting there, but not currently. So right now, if you have organ dose modulation set up, you place the patient on the scanner. You're going to do the planar radiograph, or the scout, or the tomograph, or they all have their names. We'll just call it scout for now. And when they do that, then you have the scout image on, and you'll set your scan field of view. And there will be a second box that you would just put it over the eyes. And then the system knows as it's going right here, tube current modulation might be on, and it's scanning. But when it gets to that point where it hits where you are saying that organ dose modulate, then as it scans through that area, when the CT scanner spins over anteriorly, it will immediately reduce the output. And that's all it does. It just says, okay, from here, it's low, 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 low. And then at this point, it picks back up and it goes back to normal. And it does that through the area which you indicate. And then at the point, I mean, you could be doing like a head and a face, and so then it would just go back to normal. So organ dose modulation is right now very simple. As you can see here on this, on my slide, it will only reduce the modulation, the MA over a very specific arc. So for example, you see here, these eyes are nice, well positioned inside this arc. What would happen if that head was too low? Well, then the eyes would be over here. And so, yeah, the organ dose modulation wouldn't do any good. And so that goes back to the idea of getting the patient nice and centered in the field of view. Now, what happens if the patient's laying with their head sideways? Now you got one eye over here and one eye inside it. Once again, organ dose modulation, especially for the face and the head, so the eye and the thyroid, it only works for a very specific angle. And when you're down here in the body, it does it just for a larger angle. And so once again, if the patient is too low, then the breast tissue might actually be outside of that field of view. Or, if the breast is laying pendant, so it's maybe not exactly centered, then part of that breast might be outside of the field of view. It's not perfect. You did bring up the point about deep learning, and the systems are getting smarter. So when you do the scout image, the system goes, oh, hey, there's the eyes, and it will automatically set your organ dose modulation. That is the goal, but currently it doesn't do that.
So right now it's like a box that technologies needs to put some box and label. Okay, this is the area that you need to do some modulating technique.
Yep, they get to specify that. So you could technically specify the whole field of view, and so it would do organ dose modulation not just for the lens of the eye, but for the whole,
for my eyebrow.
Yeah, gotta save your eyebrows.
Yeah.
Yeah.
But then this go ahead.
Oh, I was going to say, someone in the chat asked the question about, can you use this for pregnancy or for imaging?
This is going to lead to the second question for the pregnant woman or has a fetus, that need a CT action.
And so the answer is, yeah, you can turn this on as it sweeps over anteriorly. The answer is yes, you are going to reduce the MA to that point. Obviously, the question is, where is the baby? If it's a very second or third or late trimester, it's a late trimester birth or pregnancy, then the baby may not fully fit within this field of view. There was a paper that looked at this, and they asked the question, can you use this and would it reduce the dose to the fetus? And the answer is they said yes. And so in their case, they use this option. The one caveat I would say to that is if you are using, and I'm not trying to be negative about this, but if you're using a Siemens CT scanner, Siemens will reduce the MA on the anterior arc, and then it will increase the MA on the back side of it. So if you are a pregnant woman and the baby, and if unfortunately they're maybe not completely centered because they got a big belly, if part of the fetus is outside of that arc, it's going to get an increase of radiation. And so you have to be very careful using that one. Every other vendor out there, Canon and GE, they don't increase it on the posterior side. So in my personal opinion, that's fine. All it's doing is reducing the potential dose. And so, yeah, go for it.
I see. Yeah. And my second question is about the dose alert level. So you said that we should set a level to alert. This is like a real-time alert, or is it retrospectively alert?
Yeah. And so you can look at that as two things. I actually didn't go into detail of this. I thought about this. Is there are prospective alerts and retrospective. So all CT scanners have the ability to have an alert built into it. And so you put the patient on the table and you punch in all your parameters. And when you click confirm, the scanner will calculate and say, oh, you know what? This MA and this KV, it's actually above what we expect. And so there's an alert level built into the CT scanner. And so the system will set up what's called a dose notification window. And it'll say, hey, by the way, this exam, this scan you're about to do is going to be higher than normal. Do you want to go forward? And then you would say yes or no. I mean, if you go, oh, I did something wrong, you can back up and go, oh, I changed my KV. I accidentally put 120 and it was supposed to be 100, whatever happened. So that happens prospectively. Now, in our Radiological system, we have an alert level, and then we have a really big alert level in case something crazy happened. If for whatever reason the patient got scanned 2, 3, 4 times, I don't know, something crazy happened. In those cases, the system, Radiometrics, will immediately email me and a couple other people and say, hey, by the way, this dose was like 300% higher than it normally should be. But for all other purposes, let me go here. For all other purposes, these little dots out here that they're high, and I don't know why they're high, but they're high. So they're above right here. They're above this threshold. These values, I only look at quarterly. And so the system collects them all, and then I plot my plots like this, you see here. And once a quarter, I meet with our dose optimization team and we review them. This is a retrospective approach, and it's a matter of going, okay, what went wrong? Let's try to fix it. But like I said, if there's ever something that's really high, then the system lets me know. And then even beyond that, the CT scanner itself and our wonderful technologists will have the opportunity to make an intervention or a change if something happens in the moment.
So does it mean you recommend at least having to alert level? The one is like a really high or like a dangerous level that need to do like immediately alert, like a real time. And the second level, we can review it retrospectively, quarterly or something.
So the answer is yes. And when it comes to it, the ones that are really high, you can set an alert level in the Radiometrics. But let's be honest here. You already know about it because we have alert levels at the CT scanner. And the CT, you're not going to get that high unless you had to make a decision. And what happens when the patient gets on, you scan them, and something went wrong with the contrast. There's an extravasation or the contrast. We had this happen when the contrast squirted out of the contrast injector instead of into the patient. Mm-hmm. We scanned the patient, so contrast didn't go right. So the technologist called the radiologist up and said, this is what happened. Do you want me to scan again? And the radiologist said, I need these scans for whatever reason. So they reload it up, get the contrast back, and they go to scan again, and something else goes wrong. I mean, this is just the worst case scenario you could ever hope for. And so now you have to call the radiologist and say, it happened again. We need to do a third scan. So what I'm trying to say is when something happens out of the ordinary, at least at our hospital, and I don't know how you guys do it in Thailand, but in our hospital, the radiologist has to sign off on it.
Yes.
And if the radiologist says, yes, do it again, then we already know that. And what'll happen, at least for us in our hospital, is the technologist will say, hey, this happened. And that's when people like me go, okay, I'll go look at it. Yes, then that study will be sent to Radiometrics, and Radiometrics will have that really upper level alert that'll go, hey, this is 300% higher than it should be. And I would get that email. But I'll be honest, by the time I got that email, I've actually already been called and I already know what's going on. So the answer is yes, you could do it. And for a very busy hospital or a hospital like you guys that maybe you share a radiologist, share a physicist, then maybe it is good to have that really upper level, because then they will get email notifications immediately. And even maybe a key radiologist like a chief or a optimization radiologist, they'll get that email. And so they might not even be on service that day, but then they'll go, oh, something happened. And so they can jump in. So you can do it, but let's be honest, a lot of the time the CT scanner itself will catch a lot of those mistakes. Well, not mistakes, but issues, and it'll let you know about it.
Okay, that makes sense. Yeah. And my last question is about those reduction that you mentioned earlier, that is like a stepwise, like, okay, you know this level and now you try to reduce those a little bit. and observe for the couple months, and then next step is reduce furthermore. So my question is, since we do for the brain, let's say for the CT head, we do fixed MA, helical modes, and we also do KVs 100 for less than 2 years old and 120 for more than 2 years old. What can you reduce? Fix, so you just adjust the MA things, right? A little bit at a time.
Yep, that's a great point. And so it's exactly, when you look at this, the KV is basically set for image quality, for the contrast. So good gray white differentiation and penetration. So just like you said, basically under 2, you're 100 kV, over 2, you're 120 kV. Rough, it's a rule of thumb. But to go from this step right here, this CTDI value here, down to this one and to this one, because we used fixed MA, all we had to do is just turn our MA knob down. That's simple. If you're using tube current modulation, then what you do is, you have the noise index or the standard deviation value or the effective MA. Each vendor, each manufacturer has their own value. And what that number tells the system to do is how much noise to allow in the system. And so for a GE scanner, for example, noise index, if you're using tube current modulation, you turn the noise index up, which allows the system to let in more noise. In other words, it uses less MA. So in this case, I didn't change the MA knob. I can't turn the MA knob high or low. I can't do that. But I can say, I'm okay with a little more noise, that noise index value. And then the system will go from this step down to this step. Now, the only caveat to when you're using tube current modulation and you're trying to go from one step to the next, you set a minimum and a maximum acceptable MA on every protocol. And so when you change your noise index, it's going to pick an MA somewhere in between the minimum and the maximum. If you set your noise index, say, I want a lot of noise, and you turn that real high. Well, the problem is the system is going to lower the MA, but it's going to hit this limit and it will not go any lower. And so you can keep turning that noise index knob all you want, but it hit that minimum MA limit and it will not go any lower. And therefore you might go one step, two step, and then no matter what you change, you're not seeing any changes. I mean, no matter what noise index value you set, the noise index, the actual output would not change. And so tube current modulation, you have to change the noise index value, whatever it's called on each vendor, and you have to change your minimum maximum A. In this case, you need to lower your minimum so it allows less radiation. And so you can see it's a little bit more complicated with tube current modulation, which is fine, but fixed MA is really easy. It's just one number to turn.
I see. Yeah, I think for me, we use the fixed MA things, and 100 for less than 2 years old, and 120 for more than 2 years old. And every patient who less than 2 years old, we normally do 3D reformatted images, looking for any skull fracture. That is one part to overcome the detail on the bone that we cannot see it very well in the 100 kV. I think that's what we do here.
Yeah, and that's great because that's, going back to our last talk, there's obviously all the other features we talk about, but there's, we can do the reconstruction kernel, we can get to the dose, all that. But a lot of the post-processing techniques nowadays are just phenomenal, being able to do, 3D reformats and whatnot. And so, yeah, I mean, when it comes to optimization, that's why I say you need a team, because there are so many, going back to that, oh, there we go. Going back to this chart, if I can find it. Optimization really is a very complicated process. And when you really get down to it, what we have historically said, when we say optimization, historically, most people just think dose. And that really is only, 6 or 7 different parameters to change. But to actually get true optimization, you need to do top to bottom optimization. And so it taught, 3D reformats, image quality stuff, the right amount of dose, the scan field of view. Do we look at organ dose modulation? Are we doing the right appropriateness, set the right appropriateness criteria, the correct clinical indication? I mean, there's just all of these things we have to take into account. And it's really good to have a team look at that so no one step is missed, instead of just having the technologist do it or the radiologist or physicist do it alone.
Yes. So I think we don't have any questions from the audience right now and from the Facebook Live. But so let me ask one more question. So I know that we talk a lot about the CT head, but for the neuro study, we also have the soft tissue neck and also total spine. Can you comment on that part?
Yes, and now that I think about it, I probably up to this, everything is the same for the brain. I focused a lot on the brain because we do a lot more brain than face. But when you're doing soft tissue face, you're looking at sinuses, and then you got your, inner ear. Those are probably the next. Inner ears, obviously, you need good spatial resolution, so you need good field of view, so that you can really see the tiny detail of the bone on the inner ear. Orbits, soft tissue for the face. You need to have the right noise content, but that's kind of the same as the brain. You just optimize the right MA. Obviously, there's still bone in the face, but not as much as we don't have the cranium. And obviously, if you're doing sinuses, it's mostly air-filled. It's an air-filled cavity that could potentially be filled with infection. So, water or fluid-based. And so it doesn't actually usually require as much radiation. Typically, when we're doing face, just because when you look at the profile of the face, your face profile changes a lot more than your skull. And so using tube current modulation is great. But if you can, doing a single spin across your face, if you have the 160 millimeter scanner, that's appropriate too. Probably the most tricky, and now that I think about it, I probably should have included a slide on it, is the neck. And that's because if we're doing C-spine imaging, well, C7, it's actually down here. And so there's a lot of shoulder involvement when you're trying to image C6, C7. And so typically we're going to start about T1, T2, and we're going to image up through, C1. Most scanners are okay, but the recommendation, the recommendation I would have is if you're having a hard time getting good bone conspicuity, good edge definition when you're looking at like a sagittal C-spine, is don't image down, start imaging bottom up. And the reason behind that is I mentioned that when your system is trying to ramp up radiation, you obviously need a lot of radiation to get through your shoulders compared to your neck and even like the jaw to get up to C1, C2. And so when you start imaging right here, you don't need a lot of radiation. So you'll start with a moderate amount, but then as you start scanning down, once you get into the neck, if you look at the dose profile, it's going to go up and then it's actually going to go down. There's not a lot of tissue here. And then when it goes from this neck to these shoulders, it needs to go up really quick. And to get it to go up really quick, you either have to have a very low pitch so the system can modulate quickly, or you start at the bottom and you go up. And so it starts at the high dose. And a system could reduce the dose pretty quick. And so you can go normal dose, high dose down to low dose, and the system is perfectly fine doing that. So we had a lot of problems with our C-spines for a long time. And the biggest fix, we tried everything. We tried KVs, we tried higher MAs, we tried everything. The biggest change was when we just started imaging from the bottom up. And that's just because the system can reduce the dose from the shoulder to the neck really quick versus flipping it around. And so our biggest complaint from our radiologist was really C6 or C5 through C7. It's just when it looked at it, you just the borders of the vertebrae were kind of almost translucent and at times almost gone just because the noise content. And so anyway, that's my biggest suggestion.
This is a good point because I don't know about this thing before. I just, why image quality is so poor in the lower C5 or something, but I don't know that because of the dose stuff that we need to scan from from down
I know next week is the body. So I'll actually include a couple of slides and I'll show you what it means to go from the bottom up versus the top down. And I'll show a couple examples of a sagittal C-spine. And hopefully you'll have a good way. We can talk about it a little more.
Yeah. So which means this can help with the CT cervical spine and also CT soft tissue neck.
Definitely. Yes. Yeah. Yep.
Wow. Thank you so much, Sam.
No problem.
The excellent talk and give us more detail and very practical point to work.
Yeah.
To help with the organization in the protocol.
Yeah, there's nothing funner than talking physics at midnight, or at least midnight at my time.
Yeah. But I learned a lot from you. Thank you so much. ทุกท่านนะคะสำหรับท่านที่เข้าประชุมนะคะเดี๋ยวจะได้รับลิงก์นะคะในการประเมินส่งไปให้ทางอีเมลนะคะให้ทำการประเมินให้เสร็จแล้วก็ส่งกลับมาภายในคืนวันพฤหัสนะคะเพื่อรับคะแนน CME เครดิต3เครดิตนะคะแล้วก็ได้รับในวันศุกร์ส่วนอาทิตย์ถัดไปเนี่ยก็คือจะส่งลิงก์ให้นะคะภายในวันศุกร์เพื่อเข้าชมในอาทิตย์ถัดไปนะคะก็เดี๋ยวอาทิตย์หน้าเราจะมาพูดถึงในเรื่องของ body part ซึ่งน่าจะเป็นสิ่งที่สนุกสนานมากเพราะว่าเป็นสิ่งที่ทำเยอะแล้วก็น่าจะมีเทคนิคค่อนข้างเยอะนะคะ So thank you so much Sam and thank you so much the audience. So next week it's gonna be more fun because we're gonna talk about the body which including chest, abdomen and pelvis which gonna be a lot more fun in terms of the technique. Yeah, right, because you can because we have like the many technique to reduce the radiation dose and get a good image quality, and because of the abdomen we scan multiple phase, so that maybe another issue that we can talk about the optimization. Sure. So thank you so much everyone and thank you so much Sam ขอบคุณมากค่ะ we will see you next week. Bye bye